with the Clinical Practice Symposium on Lipid. This session will focus on the latest insight and management strategies in hyperlipidemia and cardiovascular risk reduction. It gives me a great pleasure to invite our distinguished chairs to the stage, Dr. Nisreen Al-Sayed from Bahrain and Dr. Jum'a Al-Ka'bi from United Arab of Emirates and Dr. Thamer Al-Isa from Kuwait to lead the important session. Please join me in the stage. Thank you.
Assalamu alaikum. It's my pleasure to co-share this session with Dr. Thamer and Dr. Nasreen. We're going to cover topics on lipids and our moving targets for the better for our patients regarding achieving better targets in lipid profile. Our first speaker is Professor Carlos Igor. He's a consultant cardiologist, Hospital Santa Cruz, Lisbon, Portugal, chair of the Advanced Heart Failure Cardio-Oncology, Cardiomyopathy Clinics, and the vice president of the European Society of Cardiology, assistant professor at Nova Medical School, Nova University of Lisbon. It's our pleasure to have him today with us here, and the title of the talk will be Management of Residual Risk in Hyperlipidemia. The floor is yours. Thank you.
Very good morning, and thank you to the Gulf Association for Endocrinology and Diabetes for this very honorable invitation, and also to put me in a session together with such distinguished chairs and co-speakers. I feel a little bit silly speaking about what I would consider a simple topic compared to what I've just been seeing in the previous session in the other room next door, where you were speaking and addressing about very complicated and more rare conditions. But nevertheless, sometimes it is important to go back to some of the simple things are really responsible for a lot of disease worldwide, and we also need to think about these more prevalent conditions. So on this talk regarding a residual risk, my first key message is that LDL cholesterol is a major determinant of the risk of cardiovascular disease, but this risk can remain high or even very high or extreme when LDL is considered normal by reference values, and also high and very high risk individuals, they should receive intensive LDL lowering even when LDL cholesterol is within those normal reference ranges. This is because LDL is the most important lipoprotein particle in the blood regarding the risk of atherosclerosis. It is the most abundant one and very rich in cholesterol and rather small or small enough to cross the arterial barrier. However, for cholesterol to be retained within the intima, causing the atherosclerotic lesion, which then is the substrate for cardiovascular disease, LDL needs to be modified. Those modifications cause inflammation, and so it's inflammation together with cholesterol that generates atherosclerosis. Whereas cholesterol comes mainly through the LDL, inflammation comes through LDL and the other risk factors for cardiovascular disease. And this leads us to a very important concept on how we nowadays consider atherosclerotic cardiovascular disease. It's all because of the accumulation of cholesterol. Once we've accumulated a significant amount of cholesterol in our arterial walls, then we will have our first manifestation of cardiovascular disease, which can be a myocardial infarction, a stroke, many other things, but it can also be sudden cardiac death. cholesterol accumulation is proportional to the LDL cholesterol concentration, so how much cholesterol you have, to the time that you've been exposed to that cholesterol, and that's essentially your own age, and also to the burden of those other risk factors, because they are the ones that drive the inflammation that causes the retention of LDL. And remember, without retention, LDL will not be harmful. So if you're born very young with extremely high values of LDL cholesterol, you can develop your first manifestation of cardiovascular disease at a very young age. If your cholesterol is quite high, but not as high as that very rare condition, then you will also have cardiovascular disease manifested at a young age, but not such a young age. And so it depends on how much cholesterol you have, how much years you're exposed to that cholesterol, and that will determine the age of your first manifestation. Now, that line, that threshold above which cholesterol accumulation becomes clinically apparent and relevant is movable by several factors. There is one that is protective, and that is for women who are in a childbearing age. And then there are many others that are deleterious, and I'll be speaking in this talk about triglycerides and lipoprotein delay, and later on I'll be addressing other conditions like autoimmune disease, HIV infection, and even cancer. The second key message I want to put forward to you is that LDL cholesterol goal attainment, because LDL is the most important lipoprotein particle in the blood, is fundamental to reduce mortality and morbidity in those high, very high, or extreme risk individuals. But even when you have your LDL very well controlled, you can still remain at a considerably high risk of cardiovascular disease. This is shown, for example, in these two studies, but there are many others that are alike. The IMPROVE-IT on the left-hand side and the ODYSSEY outcomes on the right-hand side, where in the treatment arm, in the experimental arm, patients were given combinations of lipid-lowering drugs that really lowered their LDL considerably, down to levels of about 54 or 48 milligrams per deciliter, with a corresponding reduction in cardiovascular events. However, is this a big success? Well, not so much, because most of the events still continue to accrue. 80 to 90% or even more of events still happen. And most of these events are atherosclerotic. So putting LDL at goal might not be sufficient. This is why we need to consider residual risk. It is the risk of ischemic events after treatment of classical risk factors such as LDL, diabetes, hypertension, and others, and achievement of those recommended targets for each of those classical risk factors. It is a substantially variable risk between persons. And so we need to assess one by one what is the residual risk of cardiovascular events in each individual. This is particularly important in patients with type 2 diabetes or with known clinical cardiovascular disease. A third message is that a common feature of individuals who have a persistently elevated risk of cardiovascular disease, despite being on LDL lowering therapy, is when they have a triglyceride level above 1.7 millimoles per liter. And so here I begin the topic of how high triglyceride levels contribute to a high residual risk. This is a very prevalent condition, even among patients who are taking statin therapy. Triglyceride levels and HDL levels can be above and below the reference values, in over a third or even over 40% of patients, particularly those who have type 2 diabetes. And this has been shown in old cohorts, but also in more contemporary cohorts, such as the NIHANES survey running between 2007 and 2014. This is not only prevalent, it is a dangerous risk factor when you have mixed dyslipidemia on top of and despite LDL lowering therapy. You are at an increased risk of ischemic stroke, ischemic heart disease, heart failure, aortic valve stenosis, peripheral arterial disease, chronic kidney disease, sudden cardiac death, and even all-cause mortality. Now, when triglyceride levels are high, above 1.7, that's 150 milligrams per deciliter, the problem is that LDL is no longer the only atherogenic lipoprotein particle. There are other lipoprotein particles that start delivering cholesterol into the arterial wall and accumulating cholesterol there, accelerating that accumulation and exacerbating inflammation in the arterial wall. Now let's have a look at the pathogenesis of this form of mixed dyslipidemia, which is a pathophysiology very close to that of insulin resistance, where we see an excess of availability of free fatty acids, and so a secretion of VLDL particles that are excessively rich in triglycerides in themselves. Now, when triglyceride levels are in excess of about 130, 135 milligrams per deciliter, so that's even a little bit below 1.7 millimoles per liter, what we see is that a transfer protein called cholesterol ester transfer protein, that's CETP on this slide, becomes active, and what it does is it redistributes triglycerides among the different lipoprotein particles in the blood, meaning it will take away excess of triglycerides in the VLDL particles, put them on the LDL particles, but in return it takes away cholesterol from the particle to which it gives the triglycerides and puts that cholesterol in the particle from which it took away the triglycerides. So this causes a major change in the composition of these lipoprotein particles, and that again happens once triglyceride levels are above those 130. Now what we see then is that LDL particles become phenotypically different. They're now called small dense LDL particles. What is the problem about small dense LDL? It's that it is very atherogenic because it is highly inflammatory, more easily retained inside the arterial wall as well, so it causes a more accelerated form of atherosclerosis with a more vulnerable atherosclerotic lesion type of profile, and so more cardiovascular events that can be fatal. Now the same kind of transfer occurs with HDL, which also becomes small and dense and are more rapidly cleared from the plasma. Now, the important thing to notice about how this all happens is that LDL is a particle that is very atherogenic, as I said to you in the beginning, because it's not only rich in cholesterol, but it's also small enough. Now, when triglyceride levels are normal, where we see most of the cholesterol in our blood is in the LDL particles. And because those LDL particles are small, they can cause atherosclerosis. They can cross that endothelial barrier. However, we also have cholesterol inside VLDL particles. But as long as triglyceride levels are normal, those VLDL particles are big and they cannot cross the arterial barrier. And so the only thing we need to take care of when triglyceride levels are normal is the LDL. But the pathophysiology changes considerably once triglyceride levels become mildly to moderately elevated. Now, we still see most of the cholesterol inside the LDL particles, but these are now those very dangerous small dense LDL phenotype. We also have cholesterol inside the VLDL, but now remember, these particles, these VLDL particles, have been modified by the activity of CETP. They are actually enriched in cholesterol, and they have become smaller because of those changes in the composition of triglycerides and cholesterol inside those particles. These are what we call remnant VLDL particles, which are small and have considerable amounts of cholesterol, and so they can also contribute to atherosclerosis. And so this is why in people who have mildly to moderately elevated triglyceride levels, we see an extra risk of cardiovascular disease. It's because they have two sources and not only one source of cholesterol causing atherosclerosis. Now, there are many other reasons why high triglyceride levels contribute to a higher risk of atherosclerotic cardiovascular disease. If you do wish to learn a little bit about some more about this, there are some nice references on the slide for you to see. I just went over some of the most simple things why these triglyceride-rich lipoprotein particles, remnants, why they increase the risk of cardiovascular disease. But this is the reason why guidelines around the world have moved away from LDL only by changing the paradigm into also assessing non-HDL cholesterol. And this is because non-HDL is all that is not HDL, and all that is not HDL obviously includes LDL, which by no doubt is atherogenic, but also other lipoprotein particles like the VLDL particles that are not atherogenic if triglyceride levels are normal, but become atherogenic if they are elevated. So because there are more particles and not only the LDL that can cause atherosclerosis, we need to determine the non-HDL level for each person, and the guidelines around the world recommend that the maximum level of non-HDL for each individual is the LDL target for that person plus, so you add 0.8 millimoles or 30 milligrams per deciliter. There are many advantages of using non-HDL as a target of treatment. I just want to highlight one of them is that it's not depending on fasting or non-fasting state, and it's very easy to calculate and inexpensive because all you need to do is to subtract the HDL level from the total cholesterol. And it also can be used as a measure of risk in patients who have very high triglyceride levels, where you know we cannot use the Friedewald formula. It's now in the guidelines, as I said to you, around the world. What should we do to these patients who have high triglyceride levels, low HDL, despite being on LDL lowering therapy? In these high-risk patients, the European Society of Cardiology and the European Atherosclerosis Society recommend that we add triglyceride-lowering therapy, which can be either fenofibrate or bezafibrate, although fenofibrate is the only of the two that has evidence from cardiovascular outcomes trials on top of the statin. The other option is to combine omega-3 fatty acids in a dose of 2 to 4 grams per day. We can also choose to do both things because some patients will have tough hypertriglyceridemia, but we should never combine gemfibrocil with a statin. In the American Association of Clinical Endocrinology guidelines for type 2 diabetes, they also recommend non-HDL as a treatment target, and also that triglycerides be kept below 150 milligrams per deciliter. And as far as the treatment options go, they're very similar to what we see in the European guidelines. Now, I want to finalize by addressing lipoprotein delay, because this has been fascinating all of us around the world. Lp(a) is the genetically determined, prevalent, and causal risk factor for cardiovascular disease, and it must be measured at least once during lifetime in every adult. Now, what is Lp(a)? This is what it looks like from an AI perspective. You know, we now use AI for everything. It's a complex structure. It combines a cholesterol-rich lipoprotein LDL-like particle with a protein, a glycoprotein, which we call apo(a). And that forms the outer cap of that smaller inside LDL-like particle. It's the most important transporter of oxidized phospholipids in the blood, and you'll see why this is important in a moment. We really don't know what is the physiological role of lipoprotein (a). We think it might have something to do with accelerating wound healing and reducing bleeding during delivery, but we really don't know why it's been favored in evolution. Apo(a) binds to ApoB on that LDL-like particle by a disulfide bond, which I'm only mentioning to you because it is that bond where some drugs are being targeted to lower Lp(a) levels. It has a very highly variable molecular mass. This is why we should be preferably measuring it in the form of nanomoles per liter and not milligrams per deciliter. And its plasma levels are predominantly determined genetically with only minimal influence of diet and lifestyle. So the gene that encodes Lp(a) is in chromosome 6. This Lp(a) gene evolved from the plasminogen gene, so it potentially could have a fibrinolytic effect, but because it's inactive and competes with plasminogen, it can actually have an anti-fibrinolytic effect, which means it can facilitate coagulation. It only exists in a few species, and this is why it's been very difficult to advance our knowledge on Lp(a) because we cannot experiment on these animals. It is almost exclusively synthesized in the liver, so that's why therapies that are RNA-based are excellent for this kind of risk factor. It's a little bit difficult advancing. May I get another one? Maybe this one's got its battery a little bit flat. Okay. There are also some small concentrations of free Lp(a), just ApoA in the blood and also in the urine, that we also don't know why that happens and what that could mean. My apologies, but it's still not working. Am I pointing to the wrong direction? Okay, I'll go testing. So as I said, it's also prevalent, and when Lp(a) becomes above 105 nanomoles per liter, this is the number we need to remember, 105 nanomoles per liter, then the risk of cardiovascular disease starts to rise in a way that is clinically relevant. But there is actually a rather continuous linear risk between Lp(a) levels and cardiovascular events. And when we look at the population levels of Lp(a), roughly about 1 in every 5 adults has an Lp(a) level that is above that 105 nanomoles per liter. Does that mean we will be treating all these patients, all these 1 in 5? We don't know yet. Thank you. There's also wide geographical variations in the levels of Lp(a). This study is the Enter-Aspire study, in which the Emirates did participate as well, just as my country, Portugal, you also see on the map. We are actually the country that has the worst, the highest Lp(a) levels. the median Lp(a) levels among the UAE patients included in InterAspire was 27 nanomoles per liter. But up to 6% of the patients in this part of the world would qualify for inclusion in ongoing randomized trials. Okay, how does this actually cause cardiovascular disease? On the one hand, because this is like an LDL particle, so it's got cholesterol, but there's much less Lp(a) particles than there are LDL. However, Lp(a) is much more atherogenic, so that's a problem. On the other hand, as I said to you, Apo(a) is capable of causing some prothrombotic effects, although these have not been shown to have a significant contribution to disease in clinical studies, but only in vitro studies. And finally, those oxidized phospholipids, which are mostly, if not all, transported by Lp(a), are very highly inflammatory, so this is what drives and accelerates atherosclerosis, but also has an osteogenic effect on valves, and so causes valvular calcification. And so this is why people with high Lp(a) have been shown to have an increased risk of myocardial infarction, particularly also peripheral arterial disease, to a lesser extent ischemic stroke and heart failure, but then also aortic valve disease. The amount of disease around the world that we estimate to be due to high Lp(a)s is round about 8.8% if we consider a high level anything above 3.8, which is extremely low. But if we use a high level of about 100, and that's very close to the 105 that I told you we need to remember, then it's about 5.8% of all cardiovascular disease in the world is attributable to Lp(a). So who should be measuring it? Every adult should have at least once in their lifetime a measurement of Lp(a). It is particularly important to screen individuals with familial hypercholesterolemia, those who have premature onset of cardiovascular disease without other risk factors, a family history of premature atherosclerotic cardiovascular disease or very high Lp(a) levels, or when cardiovascular risk is moderate or close to a threshold for treatment decisions. But it can also be recommended in pediatric ages if there has been a prior ischemic stroke, something very rare, familial history of premature atherosclerotic cardiovascular disease, or of high Lp(a) levels. How can we reduce it? Well, the interventions we have for lipid lowering at the moment are not very effective at reducing Lp(a), at least not to a magnitude that we believe, we speculate that might be needed in order to reduce significantly the risk of cardiovascular diseases. Lp(a) can be lowered by about 25% with the PCSK9 inhibitor therapy-based therapies, and about 40% maybe the most with LDL apheresis. We have several drugs, oral and injectables, that are being tested at the moment to reduce Lp(a) that will provide much more stronger reductions in Lp(a). These are the 3 trials ongoing for atherosclerotic cardiovascular disease outcomes. And on the bottom right-hand side, you'll see the name of the trial that is being, where one of these therapies is being evaluated for aortic valve stenosis. And next year, we'll likely be receiving results from 2 of these trials. So a lot of excitement has been building up over the recent years. What can we do in the meantime until we have those treatments and know whether they will be effective or not? We should apply intensive, aggressive control of all other risk factors, and intensify LDL reduction, and this is in the guideline of the EAS for Lp(a). This table, it shows how much you should try to enhance LDL cholesterol reduction in order to mitigate the risk associated with the excess of Lp(a) based on how much Lp(a) you have and when are you starting treatment, at which age. But to do that extra intensive LDL cholesterol lowering, I recommend we prefer PCSK9 inhibitors because these at least have some, although moderate, mild, but some effect on reducing Lp(a) as well. So to conclude, LDL is the major determinant of atherosclerotic cardiovascular disease, but remember that the risk can be very high even when the levels are low. It can also remain very high even after getting those levels significantly reduced by at least 50% and at goal. One of the reasons why that can happen is if you have high triglyceride levels. If you do so, these triglyceride-rich lipoproteins become atherogenic, and it's not only LDL. You need to target triglycerides as well. This is why non-HDL has become an important target of treatment as well in the guidelines. And the other reason why that risk can still remain high is if you have Lp(a) elevated. And remember, everyone in their adult lifetime needs to be measured at least once. Thank you.
Good morning, everybody. Thank you, Professor Aguirre, for the nice presentation. Delighted to also be part of the chairperson for this session, and would like to welcome our next presenter, Dr. Abdurrahman Mashi. He's a consultant endocrinologist and clinical lipidologist at the Obesity and Endocrine Metabolism Center, King Fahd Medical City in Riyadh. He has a fellowship in lipidology and cardiovascular disease from University of British Columbia, and also certified by American Board of Clinical Lipidology. He's going to give us today an update on the management of homozygous familial hypercholesterolemia. Welcome, Doctor.
Assalamu alaikum. Good morning, everyone. Thank you, Dr. Thamer, for the nice introduction. And I would like to thank the organizing committee for the kind invitation to speak about update on the management of homozygous familial hypercholesterolemia. These are my disclosures, and these are the agenda that I will try to cover in the coming 25 minutes or so. We'll go through disease overview and burden, diagnostic approaches, risk stratification, current management strategies, and emerging therapy and future directions in the field. So I will start by cases. So the first case is about Mr. M, 26 years old male with homozygous FH, genetically confirmed null mutation diagnosed during childhood, ischemic heart disease, peripheral arterial disease, and significantly elevated lipoprotein little a. He presented a few months ago to our hospital with unstable angina, and upon presentation, he was on rosuvastatin 40, ezetimibe 10, and evolocumab, and his LDL was around 17. His baseline LDL before was around 24 millimole. So what is the best next step in managing this patient? So keep the question in your mind, and we'll come back to the cases at the end of the presentation. Case number 2, 46 years old male with homozygous FH, ischemic heart disease, state post-CABG, aortic valve replacement twice, and type 2 diabetes. Currently, he's on triple combination therapy, and his LDL remain around 3.5 millimole. So the same question, what will you do next for this patient? So a little of background about the disease. Homozygous FH is a life-threatening genetic disorder with very high LDL since birth. And globally, the estimated prevalence is around 1 in 300,000. However, this figure likely underestimates the true prevalence in our region with high rate of consanguinity. And if we looked at the prevalence of heterozygous FH in our area, based on the Gulf FH registry, it is 1 in 112, which is almost 3 times the international rate of heterozygous FH. By looking at this figure, most likely we have higher prevalence of homozygous FH. Patients with HoFH are at very high risk of premature ASCVD as early as first decade of life. Therefore, early detection and management of those patients is fundamental to reduce cardiovascular risk burden. So this figure already highlighted in the previous presentation. So we know that the threshold for coronary heart disease usually around 5,000 milligram per deciliter or 150 millimole. And this threshold usually reach around, like in patients with our genetic disease, usually reach by age of 55. However, in patients with homozygous FH, they reach this threshold around 12 years old. So we have to identify those patients early on in order to prevent cumulative LDL exposure and cardiovascular disease. Little bit about genetic of familial hypercholesterolemia. We have two forms of the disease: heterozygous, the less severe form of the disease, in which we have just one mutant allele inherited by the patient. On the other hand, we have the more severe form of the disease when we have two mutant allele inherited by the patient, and that result in extreme elevation in the LDL. And the genetic variant that usually occur, the most common one is LDL receptor variant in up to 90% of the cases. And we have so far more than 3,000 variants identified in the literature, followed by ApoB, PCSK9, and the least one is LDL-RAB1, which is responsible for autosomal recessive hypercholesterolemia. These are the stigmata of familial hypercholesterolemia. We have on the right-hand side is corneal arcus, xanthelasma on the left, and tendon xanthoma in the left side, and also Achilles tendon xanthoma. So the updated criteria for homozygous familial hypercholesterolemia based on the EAS 2023, we have either clinical criteria based on the LDL cholesterol more than 10 millimole, or presence of additional criteria like tendon xanthoma before age of 10 years, or presence of LDL level in heterozygous FH diagnosis in both parents, or genetic confirmation of biallelic pathogenic, likely pathogenic variant in the gene that we discussed earlier. So moving to highlight the burden of the disease in those patients. Based on the Cascade FH registry, in 51 adults with homozygous FH, we can see nearly 80% of them, they have cardiovascular disease. And unfortunately, only 32% were at LDL goal. On the other hand, if we looked at children, 16 children with homozygous FH and mean age of 10 years, already 45% of them had cardiovascular disease, and only a quarter of them are reaching LDL goal. So we have huge burden of the disease and unfortunately still undertreated. Moving to other example from Saudi Arabia, HISA registry from King Faisal Hospital in Saudi Arabia. This is the largest homozygous FH registry in the Middle East of 127 patients. So few points to highlight. So first, we can see the mean age of diagnosis is 14.3, which is relatively later than the threshold for coronary heart disease that reached by those patients. So we having here delayed diagnosis. Other point to highlight that nearly 60% of the participants of this cohort have the founder null mutation, meaning that they will have extreme form of the disease, significant LDL elevation, and poor response to the conventional lipid-lowering therapy. Other point to highlight that elevated lipoprotein little a is prevalent among those patients. Nearly 64% of participants had elevated lipoprotein little a. The cardiovascular intervention were done in 31%, and this is just the subset of patient needed intervention, but the prevalence of cardiovascular disease is higher, and the overall mortality rate was 16%. Few other points to highlight is the medication use. Only 31% of patients were on PCSK9, and this is explained by majority of participants in this cohort were having null receptor mutation, meaning that they don't have residual LDL receptor activity, and by default, they will not respond to conventional therapy like PCSK9 inhibitor. Other point, lamivudine, only 6% of patients were on lamivudine. Part of it may be related to delayed introduction of lamivudine to Saudi Arabia. 22% receive liver transplantation, and this is mainly in pediatric as a definitive treatment, and 22% were on LDL apheresis. Moving to risk stratification as the first step in managing those patients. So we have to look for the conventional non-cholesterol risk factor like diabetes, hypertension, obesity, smoking, and other risk factor. And looking for this risk factor is to determine the intensity of treatment and LDL goal that we are aiming to achieve. Other important point to highlight, already explained well in the previous presentation, is elevated lipoprotein little a. Is a genetically predetermined risk factor for cardiovascular disease, and it is prevalent among population with 20% of overall population have elevated lipoprotein little a, almost 1 in 5. Moreover, it is more common among patients with FH. In this study, they looked at patients with FH versus no FH. Those who have elevated lipoprotein little a more than 50 milligram per deciliter, equivalent to 125 nanomole, it was more prevalent in patients with FH and associated with worse outcome. So if we look at patients with FH plus elevated lipoprotein little a, they had shorter cardiovascular free survival compared to patients with FH without elevated lipoprotein little a. Moving to the factors that are of relevant to homozygous FH, like LDL cholesterol life year, meaning that longer cumulative exposure to LDL as a result of delayed initiation of lipid-lowering therapy. So we know that LDL is a causal risk factor for cardiovascular disease, but time factor is also important. So we have to interfere in both factors of the formula, reducing LDL and minimizing the time of LDL exposure in order to reduce the plaque burden and ACVD event. Other important prognostic value is LDL level upon presentation. So if we look at the right side, so baseline LDL and diagnosis for patient with homozygous FH had a prognostic value. The higher the baseline LDL, the worse the outcome. Another important factor is genetic testing. So genetic testing will provide important prognostic information in those patients because we will know those who have null mutation, usually they have extreme elevation of LDL, poor response to conventional therapy, and by default, they are at higher cardiovascular risk compared, for instance, those who have defective LDL receptor or heterozygous FH. Last but not least in risk stratification is screening for subclinical disease by doing CTA, coronary artery CTA and echocardiography and carotid ultrasound. So this is endorsed and recommended by most of the guidelines, including International Atherosclerosis Society as well as European Atherosclerosis Society. By this, we know that those patients, they have extreme elevation in LDL since birth. So most of them, they will have evidence of subclinical disease once identified, and we start screening for subclinical disease. Moving to the treatment option for homozygous FH. So this slide illustrates the importance of differentiating LDL receptor dependent therapy versus LDL receptor independent therapy. The LDL receptor dependent, we have the conventional treatment, statin, ezetimibe, bile acid sequestrant, bempedoic acid, and PCSK9 inhibitor. And these agents will need residual LDL receptor activity in order to work. While on the other hand, we have lometopide, evinacumab, apheresis, and liver transplantation will work on those who have null receptor mutation and minimal or no residual LDL receptor activity. So the residual LDL receptor function is very critical to dictate the response to lipid-lowering therapy. As we can see in the graph, those who have 100 residual LDL residual receptor activity, they gain the maximum benefit of lipid-lowering therapy like statin, ezetimibe, PCSK9. But once they move to have very minimal LDL receptor activity, we can expect only minimal LDL cholesterol reduction. And in PCSK9 inhibitor, it can be zero response for those who have less than 2% residual activity. While on the other hand, LDL receptor independent agent like lometopide, ANGPTL3, evinacumab, and LDL apheresis provide an average 50% reduction regardless of residual LDL activity. These are the list of common lipid-lowering therapy. We have it for homozygous FH. statin approved from age of 7 years in those with homozygous FH, and the efficacy we can see it is around 25-30% in those with homozygous FH. Ezetimibe around 20% reduction. Bempedoic acid not yet approved in homozygous FH. PCSK9 monoclonal antibody, it produced an average 30% reduction in LDL in those patients. However, the benefit is related to the residual LDL receptor activity, and it is approved from age 8 to 10. Lumetopide, which is another LDL independent pathway, approved from age of 18 and produced around 50% reduction. Evinacumab, the approval recently extended by US FDA to start from age of 1 year, and in EMA and Canada it is approved from 6 months and above, and it works independent of LDL and produce 50% reduction in the LDL. We will go through these options in details in the coming slide. So the treatment algorithm for homozygous FH from European Atherosclerosis Society 2023, we start all patients with lifestyle changes, statin, ezetimibe from the start. And then within few weeks, we retest the LDL. If not at goal, we add PCSK9 directed therapy. And then we check the response. If the LDL reduction is more than 15%, then we continue. If less than 15%, we have to move to other LDL independent pathway like the lumetopide, evinacumab, with or without LDL apheresis. And the goal for treatment in children is aiming for LDL less than 3 millimole, and in adult we aim for LDL less than 1.8 millimole if no major ASCVD risk factor, or less than 1.4 if there is established cardiovascular disease or additional risk factor. That's why this is the aim of doing risk stratification early on to decide about the LDL goal that we are aiming to achieve. More or less the same from International Atherosclerosis Society recommendation, the same pathway, statin, ezetimibe, followed by PCSK9, and then we move to LDL independent pathway, and they highlighted the rule of liver transplantation as the last resort, and most of the time is done in pediatric patients. So we said earlier that those patients are remain undertreated. So few points to highlight from this international clinical collaborator registry included 751 homozygous FH patients from 38 countries, and only 12% of patients were achieving LDL goal if we apply the old recommendation, LDL less than 2.6 or less than 1.8 in primary and secondary prevention, and only 5% achieved the newer guideline recommendation with LDL less than 1.8 and less than 1.4. Important message from this study, the probability of achieving the LDL goal was correlate with the number of lipid-lowering therapy. So the higher the number of lipid-lowering therapy, the greater the chance of achieving the LDL goal in those patients. Moving to the option for treating those patients, starting with ezetimibe, in randomized double-blind study of 50 patients with genetically confirmed homozygous FH, addition of ezetimibe was better than intensification of statin and result in average 20% reduction in LDL. PCSK9 inhibitor, the mechanism of action as you know. So in patient, so PCSK9 protein usually attached to the LDL receptor LDL complex and guide them for degradation in the lysosome. With the presence of PCSK9 inhibitor, we will prevent the degradation and increase the LDL recycling to the hepatocyte surface and increase the LDL clearance. So evolocumab for the treatment of homozygous FH in TESLA Part B trial included nearly 50 patients, result in 31% reduction in LDL compared to placebo. Important to highlight that the response was variable based on the genetic background of the patient, ranging from 0, no response, up to 41% reduction. More or less the same aliricumab in Odyssey homozygous FH in 70 patients at week 12 result in around 36% reduction in LDL compared to the placebo, and the same message, the response was based on the genetic background. inclisiran. So the mechanism of action, so it is different from PCSK9 inhibitor. This is work directly on the level of the messenger RNA translation. It is a small interfering RNA that targeted the translation and synthesis of PCSK9 protein, and the end result will be degradation of PCSK9 messenger RNA, eventually low PCSK9 protein, and increase the LDL receptor recycling and LDL cholesterol clearance. It was evaluated in 2 separate studies in patients with homozygous FH. The initial one, Orion 5, included 56 homozygous FH patients more than age of 18. Unfortunately, it was negative trial. No statistically significant difference in LDL compared to placebo. A more recent trial, they evaluated 13 homozygous FH patients in adolescent age between 12 and 18, and inclisiran in this trial resulted in 33% reduction in the LDL. The reason is clear for the negative trial in the first one. Most of the patients in the first trial were null receptor mutation with very minimal LDL receptor activity. As we discussed earlier, we expect no response in those patients. Moving to the LDL receptor independent option, we have lometopide, is a microsomal triglyceride transfer protein inhibitor. So that inhibit the assembly of chylomicron and VLDL in the intestine and the liver, and the end result is decrease the lipoprotein production. And the administration of this medication is 5 milligram orally daily, titrated to the maximum dose of 60 milligram daily. It results in average 50% reduction in LDL. However, it has own side effect with hepatotoxicity, elevated liver enzyme, fatty liver, as well as GI side effect from fat malabsorption and steatorrhea. So in 2 international registry, the first one, lower registry, included 223 patients with homozygous FH and mean of duration around 39 months. Use of lometopide result in around 45% reduction in LDL. On the other trial, they included 75 homozygous FH patients across Europe. It is a pan-European retrospective observational study, and the average LDL reduction was around 60%. So we have a real-world evidence for the efficacy of this medication. And in lower registry, the longest duration for a patient was around 9 years. So we have long-term follow-up for this medication. Evinacumab, another LDL-independent option. It is a fully human monoclonal antibody that binds to the ANGPTL3. Don't know if the pointer is working. So as you can see here, evinacumab inhibits the ANGPTL3 and result in upregulation of lipoprotein lipase, endothelial lipase. By this, we will have increased lipolysis and clearance of VLDL, IDL through LDL receptor independent pathway. By this, we have less conversion of IDL to the LDL, and the end result will be less LDL level. And the idea behind discovery of this medication, it comes from genetics. So loss of function variant in ANGPTL3 associated with low LDL, low triglyceride, as well as less cardiovascular risk compared to the patient who have normal genetics. So the administration is 15 milligram per kg IV infusion once monthly, and the adverse effect overall are minimal, just infusion-related reaction and nasopharyngitis with powerful LDL reduction around 50%. So in ELLIPSE homozygous FH trial evaluated the effect of evinacumab against placebo in 65 homozygous FH patients aged 12 years and above, randomized 2-to-1 approach. At week 24, there were around 50% reduction in the LDL. Important point to highlight in this trial, they compare the subset of patients who have null mutation versus non-null, and both groups have the same benefit, which is around 50% reduction. Again, this is confirmed that this medication works independent of the residual LDL receptor activity. Moving to other option, LDL apheresis, extracorporeal removal of atherogenic lipoprotein Again, it is invasive procedure, require access, and frequent weekly or bi-weekly. The acute reduction is around 70%, and the mean interval reduction is around 40%. So the emerging therapy and the future direction in the field. So we have the either doing RNA-directed option, small interfering RNA. We spoke about inclisiran, and we have in the pipeline zodasiran. On the other hand, we have DNA-directed therapy with base editing or overall replacement of the LDL gene or prime editing. And these are the way that they use it for delivery, either viral vector or non-viral vector by lipid nanoparticle. Zodasiran is probably the nearest to the clinical practice. It's a small interfering RNA targeting ANGPTL3, now enter the phase 3 trial and started recruiting, and they are aiming to recruit 60 homozygous FH patients. We will discuss the result of the phase 2 trial in the coming slide. RGX-501, it is again a viral mediated replacement of LDL receptor gene. Initially, it showed excellent result. However, the company terminated the project. Exosomal LDL receptor messenger RNA, it is replacement of LDL receptor with messenger RNA. The idea of this approach is to replace the defective LDL with, like we call it, innovative way of transmitting the LDL receptor to the liver and restoring the LDL receptor function. Other option, VERF201, it is a base editor aiming to permanently inactivate ANGPTL3. So it is once and done approach, single infusion to permanently inactivate ANGPTL3. In the preclinical trial, it showed excellent result, more than 50% reduction in the LDL, and now they are in the phase 1b trial aiming to recruit 36 patients. Last but not least, CRISPR CTX310. It is another way of doing gene editing to inactivate hepatic ANGPTL3. In the preclinical study, it showed excellent reduction in both LDL and triglyceride, up to 80% reduction. And now just a few months ago, the company announced positive result of phase 1 trial, and they are going to present their data next month in the American Heart Association meeting. Zodasiran, as we discussed, it is a small interfering RNA that inactivate ANGPTL3. In gateway trial, in phase 2 trial of 18 homozygous FH patients randomized to receive either 200 or 300 milligram subcutaneous, and they looked at the LDL reduction was significantly compared to placebo, up to 46% reduction in the LDL, and safety overall was favorable, no major adverse effect or discontinuation of treatment or death. So let us go back to the cases. Case number 1, patient with homozygous FH, null receptor, ischemic heart disease, peripheral arterial disease, elevated lipoprotein little a, already on triple combination therapy, and his LDL remain around 17 millimole. So what you will do next? So clear, we will add LDL independent agent. We added lometopide, 20 milligram. This is the maximum dose he could tolerate, 20 milligram daily, and his LDL reduced to around 7.2 millimole. Again, it's still far from the goal that we are aiming. The next step, we discussed with him the LDL apheresis or ibinacumab. He's totally reluctant to consider apheresis, so we will move with him by adding ibinacumab. The second case, 46 years old male with homozygous FH, ischemic heart disease, state post-CABG, and AVR type 2 diabetes. On triple combination therapy, his LDL remain around 3.5 millimole, which is almost double the goal that we are aiming to achieve, less than 1.4 millimole. So we added lometopide, and again, he is on lometopide 20 milligram daily for now almost 1.5 years, and consistently his LDL remain below 1. In conclusion, homozygous FH can lead to ASCVD as early as first decade of life and remain underdiagnosed and undertreated. So early recognition and intensive therapy are crucial in order to prevent cardiovascular burden in those patients. LDL receptor independent therapy have reshaped homozygous FH management and result in paradigm shift. Gene-based therapy offer a hope for curative potential in the future. And thank you.
Thank you so much, Dr. Abdurrahman, for update on homozygous familial hyperlipidemia. Each time I remember this topic, I say, why we don't have it in the premarital screening? We have lots of diseases, but this is something preventable, so we should include it there. And back to Professor Carlos, and the talk will be on hyperlipidemia in special population. Thank you.
Once again, and I think that this topic also shows how another trend is happening in the field of dyslipidemia, which is that we're starting to interface much more with other medical specialties. And so lipid management has gone beyond cardiovascular medicine or metabolic medicine, and it's now into several other fields. So I'll be addressing 6 special populations, specifically because there's recent evidence and recommendations in the guidelines regarding each of these 6 individual types. Acute coronary syndromes, the category of extreme cardiovascular risk, autoimmune disorders, HIV infection, cancer, and also severe hypertriglyceridemia. Let's start with acute coronary syndromes. The one thing we know about patients with acute coronary syndromes compared to those who are in a chronic ambulatory state of their coronary artery disease is that they face a high early risk of fatal and non-fatal complications. This is both the case for ST elevation acute coronary syndromes, but also non-ST elevation acute coronary syndromes. Overall, we see that about 1/3 of the 2-year mortality and 1/3 of the 2-year composite of fatal and non-fatal coronary events occur in the first 3 months after an acute coronary syndrome admission. So we need to strike early and strike strong, and I know you will be hearing more about this in one of the next talks. Why do patients with acute coronary syndromes have such an exacerbated risk of cardiovascular events that is very early after the acute coronary syndrome? On the one hand, because they most often present multiple coronary plaque ruptures, and each rupture can be a potential new event, much more commonly than patients with chronic coronary syndromes. On the other hand, because once you have an acute coronary syndrome, there is a pro-thrombotic state, a hypercoagulable state that lasts up to about 6 months after the hospital admission. So well into while you already are ambulatory and back home, you are still at a high risk of thrombotic complications. And also because an acute myocardial infarction is also an inflammatory event, and what we see is an acceleration of atherosclerosis in the coronary arteries after an acute coronary syndrome. And that lasts for several months before the velocity of progression of atherosclerosis in the coronary arteries goes back to the normal velocity it had before the acute coronary syndrome. So definitely, we need to be very aggressive and quickly manage to achieve the LDL goals in patients with acute coronary syndromes. Unfortunately, a lot of the observational data, the real-world registries, show that drugs, lipid-lowering therapies, are very seldomly up-titrated after discharge. And so, because this early risk, we have decided to change the guidelines in a way that we, during the hospitalization, start to aggressively manage LDL cholesterol. So the current recommendations, as they also state in the 2025 focused update of the 2019 ESC-EAS guidelines for the management of dyslipidemia, is that if the patient was not on lipid-lowering therapy before admission for an acute coronary syndrome, then we should consider combination therapy rather than only a statin, using high-intensity statin plus ezetimibe to reach that LDL goal more quickly than what we would probably be reaching if we were to use the statin therapy alone. If the patient is admitted on lipid-lowering therapy, and this does happen every now and then we need to intensify whatever lipid-lowering therapy they're on by adding other lipid-lowering drugs or intensifying the drugs that we are using. And to not forget that the first reassessment of the lipid profile should be early, around about 4 to 6 weeks after hospital discharge, and lipid-lowering therapy should be escalated if those targets are not met. The second special population is that of extreme cardiovascular risk, which has now gone into the new guidelines, the updated focus update of the EAC-EAS guidelines. Extreme risk are who? These are individuals who have had recurrent ischemic events. Now, it doesn't matter how long between the two events, whether it's been after a few months or after several years. If you've had multiple ischemic events, myocardial infarctions, strokes, combinations of those, then you need to be more aggressively treated. The other group of people that belong to this extreme risk category are those with polyvascular arterial disease. What is this? This is people who have at least 2 of the 3 territories with clinically manifested disease. So they either have coronary disease plus peripheral arterial disease or cerebrovascular disease. Any combination of at least 2 of these is what we would call polyvascular disease. And in these cases, we should be aiming for an LDL below 1.0. Now, myself and others have put forward a consensus document that's been recently published in May this year in one of the European Heart Journal journals, the one dedicated to cardiovascular pharmacotherapy, where we recommend that reaching these goals is very difficult on statin monotherapy. And so our recommendation is that we use upfront combination therapy much more than what we've been using before. And that could even mean a triple combination of treatments, such as statin, ezetimibe, and bempedoic acid, in order to reach that goal more quickly in the very high-risk patients. It all depends on where your baseline LDL cholesterol is before treatment is started. If it's too high, and it's predictable that we will not reach that goal with a combination of 2 or with a single statin therapy, then it's even a good idea in that case to start with triple therapy. The third special population is that of autoimmune disorders. These individuals have got an increased risk of cardiovascular disease compared to matched controls from the general population. This is a very elegant observational study that has shown this in the United Kingdom, following patients in both primary care and also in secondary care, where they matched almost 450,000 individuals with autoimmune disorders, any one of a list of 19 autoimmune disorders, to over 2 million controls. And over a median follow-up of only 6 years, there was a 56% increased risk of cardiovascular disease. A lot of these people did not even have a single lipid profile, which shows that in autoimmune disorder management, lipids have not been considered, and very few are on statin therapy. This is the list on the left-hand side of all the 19 autoimmune disorders. There is no autoimmune disorder that is not on the list. Any one of them increases the risk of cardiovascular disease. The magnitude is from about 1.4-fold to 3.6-fold increase, with the highest excess risk attributed to systemic sclerosis, followed by Addison's disease, and systemic lupus erythematosus. Overall, autoimmune disorders accounted for a population attributable fraction of cardiovascular disease of 6.3%. And the age at the time of the first cardiovascular manifestation among individuals with autoimmune disorders was about 4 years earlier. So it's more prevalent and it's more premature in people with autoimmune disorders. I apologize, I think this is not reading very nicely over there, but what you would see on the left-hand side is 12 different forms of cardiovascular disease, from heart failure to valvular heart disease, venous thromboembolism, pulmonary embolism, arrhythmias, whether they're supraventricular, ventricular, or sudden cardiac death, myocarditis, pericarditis, endocarditis, aortic aneurysm, all forms of cardiovascular disease, all forms, the entire textbook of cardiovascular medicine, all of those forms of disease are increased in patients who have autoimmune disorders. I want to highlight the particular case of psoriasis, which is a rather common condition, and these patients often smoke, they are often obese, they also have often less good mental health because of their condition, which is somewhat stigmatizing to them as well. All of this puts their risk of cardiovascular disease at a higher level of about 50%, particularly the risk of stroke, myocardial infarction, and also cardiovascular mortality. This is all because of mediator cytokines that are released by the immune cells in the lesions. They are released into the circulation and they cause endothelial activation, thus promoting and accelerating atherosclerosis. Also, in these individuals, the classical modifiable risk factors such as smoking, I told you before, are more prevalent. They are more underdiagnosed, and I've shown to you that lipid profiles are not tested in these individuals most of the time, and they are more untreated and less controlled. So it's on the one hand because of a higher burden of the typical risk factors for cardiovascular disease, but on the other hand, it's the pro-inflammatory state caused by the autoimmune disorders that drives the risk of atherosclerosis. So the guideline recommendations are that individuals with chronic inflammatory diseases must be recognized as being at a higher risk of atherosclerotic cardiovascular disease. So we need to seize the opportunity and assess their risk every now and then, taking into account that the presence of these conditions is important, particularly when patients are at the limit of a threshold for preventive intervention, such as when they are moderate risk by the calculators. The cumulative disease burden and the recent degree of inflammation are important determinants of the risk-enhancing effect. So one of the most fundamental attitudes to controlling cardiovascular risk in patients with autoimmune disorders is to have a good control of the inflammation in itself, so to control the disease, the autoimmune disease as well. Cardiovascular risk in these individuals should be treated with similar interventions as in the general high-risk population, because there is evidence that traditional methods such as lipid-lowering treatments are just as beneficial in preventing cardiovascular risk in these patients. The fourth special population is that of people living with HIV. The risk of atherosclerotic cardiovascular disease is doubled in patients with HIV. They have a higher risk of arrhythmias, of peripheral arterial disease, strokes, various clinical manifestations of coronary heart disease, such as myocardial infarctions. They have more often sudden death and also heart failure. And so they deserve special attention regarding cardiovascular prevention. Why do these individuals have a higher risk than the non-infected population? On the one hand, it's because they have a higher burden of classical risk factors. They are more often smokers. They tend to also have more often high blood pressure and hypertension. But also diabetes and dyslipidemia seem to be more common in these individuals than in non-infected individuals. So that in itself is already a strong reason why they have a high risk of cardiovascular disease. The other is that they have an infection that is not curable and that causes chronic inflammation and immune activation, which is even worse if they are co-infected with other viruses such as hepatitis C and cytomegalovirus. And so this chronic inflammatory condition also drives a chronic thrombotic tendency, and this is why the HIV infection, just by itself, independent of all the rest, is a risk factor for cardiovascular disease. Finally, some of the antiretroviral therapies that we use to control HIV infection and the replication of the virus can have adverse effects, such as abacavir, ritonavir, lopinavir, endinavir, and darunavir. They can either activate the endothelium, or they can activate platelet aggregation, or they can cause insulin resistance, dyslipidemia, and type 2 diabetes. These are the current guidelines. Every year, the European Association for the Clinical Study of Diabetes releases a new version of the guidelines. It's continuously updated, and on the far bottom right, you will see the targets for LDL cholesterol and non-HDL cholesterol for individuals who are living with HIV, whether they are high or very high risk or in secondary prevention. Now, what is the news? The news in this area is that we had no doubt that patients who were living with HIV, if they are high or very high risk, should be receiving statin-based therapies and lowering their LDL. We were not sure about whether individuals who were not high or very high risk, so younger individuals living with HIV, and perfectly in primary prevention, whether because of that pro-inflammatory state, they would not benefit from statin therapy as well. And so this was tested in a US trial called the Reprieve trial that was funded by the US government some years ago. The statin that was chosen was pitavastatin because of its very favorable safety profile in patients who are taking antiretroviral therapies. And the trial was actually prematurely stopped because of an excess benefit of the statin over placebo during a median follow-up of 5 years, as you see on the left and the right Kaplan-Meier curves. So for this reason, the European Association for the Clinical Study of HIV and AIDS now recommend that even for the low to moderate cardiovascular risk individuals, we should consider a statin, and they particularly indicate a moderate intensity statin. I must say that the European guidelines that have just been recently updated, they are stronger in the statement. They give a class 1 recommendation. If you are an HIV-infected person, regardless of how well your infection is being controlled, you should be on a statin in order to reduce the risk of cardiovascular events. Obviously, the choice of a statin must be based on the potential drug-drug interactions. The fifth special population is that of cancer. We know more and more now that it's not only cancer that drives atherosclerotic cardiovascular disease. Atherosclerotic cardiovascular disease also drives cancer. We see cancer is more prevalent among individuals living with heart failure, for example, although we're still not sure what the mechanisms are. But there is certainly increased risk of cardiovascular conditions in patients who have cancer. Some of those risks only develop several years after surviving the cancer, when maybe all of us, including the patient, have forgotten that the patient even had a cancer before. So we should not forget that cancer patients need to be monitored closely for the rest of their lives regarding the risk of cardiovascular conditions. There have been a number of small trials showing that statins significantly reduce the toxicity of anthracycline therapies. And so patients who have undergone chemotherapy using an anthracycline should be put on a statin. This is what is now a Class 2A recommendation in the current focused update of the dyslipidemia guidelines, and that's to reduce the risk of developing cardiotoxicity manifested either by a reduced ejection fraction, and so heart failure and adverse left ventricular remodeling. Finally, on to severe hypertriglyceridemia. I won't go much into the approaches that are possible to reduce triglycerides. There are a number of those. The ones that have been coming out, that have been coming through with bigger success, are those that achieve increased lipolysis to release the fatty acids from those triglyceride particles into the adipose tissue and the skeletal muscles. And in particular, it is the ApoC3 synthesis by reducing this, or otherwise by inhibiting angiopoietin 3, that are the most important forms of reducing those excess triglycerides. Also, the other possibility is to use RNA interfering agents to reduce the synthesis of angiopoietin-like 3. So there are a number of agents that are available that are under study. Some of them still are under study. But volanesorsen has already been approved after clinical trial evidence, the APPROACH trial in familial chylomicronemia syndrome, and also in another trial, the COMPASS trial in multifactorial chylomicronemia, but it's now been approved by the European Medicines Agency for adults with this genetically confirmed condition at high risk for pancreatitis. And in this case, the EAC-EAS focused updates for the dyslipidemia guidelines have now given it a Class 2A recommendation to reduce the risk of pancreatitis. Although I am addressing severe, or want to address severe hypertriglyceridemia, it is interesting to notice that some of these agents are also moving into the field of cardiovascular outcomes and not only reducing the risk of acute pancreatitis. And one of these agents is plozasiran, which is going to be tested in a trial called CAPITAN, that's planned for that cardiovascular outcomes assessment. The other agent that's also undergoing that's undergone approval by the FDA and is undergoing review by EMA is olezarsen, also for reducing triglycerides, and they managed to reduce significantly triglycerides by over 50%. I also want to finish, like our previous speaker, with just a word of hope. There is so much going on in the field of lipids. This is an incredibly fast-pacing field with lots of new interventions, interesting approaches as well, using technologies that are potentially cheaper than monoclonal antibodies, for example, and that are more scalable to reduce the prices of agents as well, as we more and more see now with special populations, with residual risk, that we really need to be using much more lipid-lowering therapies in more individuals, and also much more combinations of lipid-lowering therapies in the same individuals. And so price is going to be something very important alongside safety and efficacy, of course. But just to leave you with, I won't go over this, with an idea that there is a lot moving forward in this field, and I hope that we will have good news for our patients and for all of us in the near future. Thank you very much.
Thank you very much, Dr. Carlos and Dr. Abdurrahman, for the elegant presentations and very informative presentations. We started actually 7 minutes late, so we have, instead of 15 minutes Q&A session, we're going to shorten it to around 7 minutes. So I open the floor for discussion. Very fascinating talks. As we know, a very fast-pacing field in lipidology. A lot of things, I'm sure, crosses your mind. Go ahead, Dr. Jama, your question, please.
Assalamu alaikum. Thank you so much, Professor Carlos. Regarding the value and the residual risk, what about omega-3, especially the purified form, like EPA, Basiba, I think it's called. And when you go to use it, any indication, how strong is the indication for it? We have only one microphone.
Another one is on the way. Thank you so much for the question. This is now formally recommended in the guidelines with a class 2 recommendation in individuals who have a high or very high risk for cardiovascular disease, particularly those that have had a myocardial infarction or an acute coronary syndrome, and who, despite having their LDL controlled, still remain having high triglyceride levels. For these individuals, we can reduce that excess cardiovascular risk by using icosapent ethyl. There is strong evidence from the REDUCE-IT trial. For the other omega-3 formulations, namely the ones that combine EPA with DHA, the evidence is older, so it comes from trials in eras where there wasn't intensive LDL lowering as we are using it today. Nevertheless, there is still strong evidence and evidence that compares IPE, so the EPA only with the EPA and DHA, that combination is also capable of reducing cardiovascular outcomes. But the trial on top of strong LDL lowering is a REDUCE-IT trial with the IPE.
Thank you. Another question? Yes.
Nice talks from both speakers. I have 5 questions, but I'll only ask one.
5 questions? That's
One,
a lot.
I'll ask one.
You have one, there are others.
Okay, I'll reduce it to one. Abdurrahman, if you have the 2 medications, lumitapib or evinacumab, in an adult person, which one would you prefer and why?
Yeah. If we look at the 2 agents, so thank you for your question. So if we have the both option available, then we have to look for the side effect profile. We know the side effect with lumitapide, GI upset, fat malabsorption, elevated liver enzyme, fatty liver disease, the need for close monitoring. So I will go with evinacumab, but don't forget that it is a monthly infusion. So we have to look for the patient profile if they can come every month in-house to get the IV infusion. So both medication have comparable efficacy, but if we look to the downside of each agent, I believe that more with lumitapide, especially the side effects, so I will prefer to go with evinacumab.
Yeah, I have. Yes.
Yes. My question about use of aspirin as cardiovascular prevention. We used to use it extensively in diabetes, and then with time, we are not using it that much. What's the current recommendations for aspirin use?
Aspirin, thank you for your question. Aspirin should be used undoubtedly as a preferred antiplatelet agent in patients with type 2 diabetes who already have established atherosclerotic cardiovascular disease. There is no doubt. In those that do not have established atherosclerotic cardiovascular disease, we need to assess the risk of cardiovascular disease in patients with type 2 diabetes, and probably it's only for the very high risk type 2 diabetes patient that the risk-benefit of taking aspirin might be favorable. It will not be favorable if the patient has a high bleeding risk, a high GI bleeding risk, if they have a history of peptic ulcer or GI bleeding, for example. Those patients we should probably not be using in a primary prevention setting. We should not be using aspirin. What I believe has happened over the decades that has changed this paradigm, where we used to use aspirin much more in patients with type 2 diabetes, is that we are interfering much better now with the substrate of atherosclerotic cardiovascular disease in patients with type 2 diabetes, which is the atherosclerotic process. We're now much better at controlling the LDLs and the triglycerides as well. We are capable of using cardioprotective and renoprotective agents also for these patients with type 2 diabetes. And so the residual risk has gone significantly down. And that's if the bleeding risk is now a little bit high, then the balance in primary prevention will be unfavorable for aspirin. So only a few patients. One type of patient where you might consider giving, and I would consider giving with type 2 diabetes in primary prevention, is the one that has got a high calcium score. Calcium scores are now much more easily available. Very low radiation, you don't need any contrast administration, so no nephrotoxicity there. If you have a calcium score above 100, that is a reason to take aspirin. If it's above 300, that patient should even be seen as a secondary prevention patient and not a primary prevention patient.
Thank you. I think I will take just one more question.
Professor Aguirre, checking LDL lipoproteins once in lifetime, how are you going to monitor these patients? And if it is non-HDL monitoring, would that be enough to tell us that the lipoproteins are improving? And my very short other question is that, would you consider the American atherosclerotic cardiovascular questionnaire to risk stratify patients with hypercholesterolemia to consider starting them on medications?
Thank you for both questions. So yes, Lp(a) is included, the cholesterol inside Lp(a) is included in the non-HDL cholesterol. But why do we still need to measure Lp(a) and still measure the triglycerides? It's because non-HDL is a package of several things. You have LDL, you have the triglyceride-rich lipoprotein particles, and you have Lp(a). And the three things have different treatments. So I need to know how much and how will I distribute the treatment, what treatment options do I need based on those three things. So non-HDL is the whole picture, but I then need to know the three colors in the picture to know how I'm going to treat the patient in a comprehensive way. Regarding your second question, we now have the score to Asia for the Gulf countries, the Middle East, down to Southeast Asia. We now have an adaptation of the score 2, which is the modern score calculator of the European Society of Cardiology. It's been adapted and published last year ahead of print, this year in print in the European Heart Journal. And the calculator is available for each of the countries in this region of the world as well. So you can use a calculator that is adapted to your geography coming from the score 2 calculator. It's score 2 Asia.
I think score 2 still includes age 40 and above.
Yes, it does.
Yes, yeah.
Yes,
Yeah.
It's always above 40 years of age and up to 70 years of age. So it's that middle range of population.
Yeah, which is a
limitation.
bit controversial limitation for the region, given the fact that the cardiovascular presentation is 10 years earlier in the region. So we hope to see a risk calculator in the region that takes into consideration younger age group. But that's a good one from European society. I think with that, we would like to conclude. And I think we're going to thank you very much for our speakers for the excellent talks. Thank you very much. And our next is the symposium. Yeah. Yeah, sure.
So we're moving on to our next talk. This is going to be in behalf of GSI Pharmaceutical as a symposium presented by Dr. Hawazin Arif. She's a section head diabetes endocrinology at King Abdulaziz Medical City in Western Region. Ministry of Health, Ministry of National Guard, Health Affairs. She's also Associate Dean of College of Medicine, King Saud Abdulaziz University, and she's Assistant Professor of Medicine and Endocrinology. And she will come and talk to us today about transforming homozygous familial hyperlipidemia management, a decade with Lamotidabide.
Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee and the scientific committee for the outstanding symposium and the very rich scientific lectures. And I would like to thank Casey for giving me this opportunity to present. And I apologize, as you will notice, that there is a lot of overlap between my lecture and the lecture of Dr. Abdurrahman Mashi. So without any further ado, let's proceed. Is it not working? Okay. It's a little, it's not working. Just a touch? Because okay, so the outline of my lecture would be that I'll be giving a brief background on homozygous familial hypercholesterolemia, since the speakers has already talked about it, and then I will be focusing on the European Atherosclerosis Society diagnostic and treatment algorithm for HoFH, and I'll briefly touch on a decade of experience using Lamotidabide. And as we've been talking about in the previous lectures, that certainly as we age, we have an increased risk of developing atherosclerosis. However, in patients that have genetic mutations that is caused by absent or greatly reduced LDL receptor activity, or resulting in severely elevated LDL levels since birth, those patients tend to have a much earlier onset of coronary vascular disease. And as been mentioned as well, that the historical incidence or the historical prevalence of homozygous hypercholesterolemia was reported as 1 in a million. However, we know for sure now that it's much more higher than that, so it is like 3 to 6 times more elevated. So it has been reported that it ranges between 1 in 160,000 up to 1 in every 300,000. So the genetic and metabolic basis of this HoFH is basically due to mutations in the LDL receptor gene, and that's in up to 80% of individuals reported in the registry from Saudi Arabia. And of course, there are other less usual mutations that are related to the factors related to the receptor, which is ApoB, PCSK9, and LDL-RAP1. And if we look at the reason why it's very high in the Gulf countries, is going back to the consanguinity. So there is a very high consanguinity rate in the Gulf countries, as high as 50%. And if we look at a survey that was conducted earlier in 1995, and later in 2014, we see that actually this rate of consanguinity did not show any decline across the 2 generations. So homozygous familial hypercholesterolemia is associated with extremely premature cardiovascular events and mortality, and events that occur in childhood and adolescence, up to 100 times fold elevated risk of fatal myocardial infarction versus those that do not have HoFH. And for this reason, it is very critical to detect it early and to treat it aggressively. So how do we diagnose HoFH? Very classical, we have the tuberous xanthomas occurring, for example, as we see here on the elbow. We have tendon xanthomas that occur early. xanthelasmas, and corneal arcus. It is very important to know that the presentation in children might be atypical, so they might be diagnosed as having skin warts, and that's why they tend to be missed, and perhaps they might be seen by other subspecialties, for example, dermatologist, pediatrician, and without actually ordering a lipid profile, that can be missed. So as we mentioned earlier, the 2023 EAS criteria for diagnosis of homozygous familial hypercholesterolemia, for the clinical criteria, you need an LDL cholesterol that is not treated, that is above 10 millimoles, equivalent to 400 milligrams per deciliter. Additional criteria are the presence of cutaneous or tendon xanthomas before age of 10 years, and or untreated elevated LDL levels consistent with heterozygous familial hypercholesterolemia in both parents. And of course, if you have access to the genetic criteria, then that can be diagnosed genetically by doing a genetic test. So again, in the same consensus, we highlight on if we identify a patient who has phenotypical characteristics, for example, they have an untreated LDL level that is above 10 millimoles per liter, then it is very important to rule out secondary causes such as nephrotic syndrome, primary biliary cirrhosis, or untreated hypothyroidism. And then we need to look at the skin, make sure that the patient does not have any features that may suggest a diagnosis, the phenotypical diagnosis of homozygous hypercholesterolemia. And then we do further workup assessing the vascular status. If we had the facility to do a genetic test, then we can do that, and that is to differentiate between this disorder and very other rare forms of dyslipidemias, such as cystosporine or atypical presentation of LAL-D. So as we mentioned, that once the patient phenotypically is diagnosed, then the patient needs to go and have further imaging, so an echocardiogram, looking at the valves, also the coronary CT angiography. And as we can see in this particular group of patients, they have a very unique supravalvular aortic stenosis in those patients. So it's very important actually to thoroughly evaluate them, have coronary angiography as well, and to do a follow assessment of their cardiac status and request cardiac imaging. So what do we do? Once that is done, then we should promptly initiate treatment, and there should not be any delays in such treatment, as we're aware that as per the guidelines, we have to maintain LDL level less than 1.8 millimoles per liter if the patient does not have any major cardiovascular risk. However, if the patient has atherosclerotic cardiovascular disease or has a major cardiovascular risk, then our target should be as low as less than 1.4 millimoles per liter. So we start with the classic LDL receptor medications, a combination of high-intensity statin and ezetimibe, and then within 8 weeks, if we do not achieve a target, we should add a PCSK9. We should not stay long on PCSK9, so maximum 2 doses. If we don't see any response, then at that stage, we should consider a non-LDL receptor medications. So our plan is if we see a response with PCSK9, we continue. Otherwise, if not, then we should stop the PCSK9. If the LDL goal is not yet reached, then the options would be either LDL apheresis or lumitabide with or without ANGPLT3 directed therapy. And as we see, the response to statin and ezetimibe and PCSK9 is dependent on the degree of the residual LDL receptor activity that is available. However, in the case of apheresis, lumitabide, and PTL3 directed therapy, the response here is independent on the LDL receptor function, and that is why it is very, it is very useful and very efficacious to be used in those patients. So what about LDL apheresis? It's been present for a long time. It is quite effective in reducing LDL cholesterol. However, we have an issue of that this particular therapy is intrusive to the patient's life, so the patient has to go for this LDL apheresis every 2 weeks. It requires a venous access. It requires days absent from work. So yes, it's effective. However, it's unfortunately intrusive to the life of the patient. So over the past 10 years, we have introduced the LDL receptor independent therapies, the lumitabide. Lumitabide is a selective inhibitor of the microsomal transfer protein MTP, an intracellular lipid protein. It plays a key role in the assembly of the ApoB containing lipoproteins, so it prevents the formation of chylomicron in the intestine and the VLDL in the liver, so this will result in reduction in the circulating levels of LDL. So it has no relation with the LDL receptor. Looking at the pivotal trial of lumitabide, yes, we see a significant effective reduction by week 26 by an additional 40 to 50%, and even up to 294 weeks, which is more than almost 5 years, we can see that the effect of lumitabide in lowering LDL cholesterol is still maintained. So what about in terms of what we're interested in, cardiovascular prevention? So we do have actually a reduction in the incidence of MACE with lumitabide. So if we look at the MACE incident rate, 1,000 persons in 2 years before lumitabide and 2 years after the lumitabide, we can see that the incidence rate reduced from 21 to 7.4, showing a reduction in the use in the MACE 2 years post lumitabide treatment. One of the questions earlier that was raised was the GI side effects. Yes, because of the mechanism of action of lumitabide is through inhibition of the formation of the chylomicron in the intestine. So yes, we do see some side effects with the use of lumitabide, particularly if you look at the initial month of starting such therapy, since as you know that patients that are using lumitabide has to be on a strict low-fat diet. So once the patient gets used to this diet and once the patient actually uses the medication the correct way that should be done, then we can see that those side effects with time, they tend to fade away. Very important, again mentioned earlier about the monitoring of the liver function test. Again, because of the mechanism of action, we need to monitor the hepatic markers and also look at the hepatic images. So if we see that the blood markers of hepatic inflammation and fibrosis are actually stable over the time that the lumitabide was used, and also if we look at the liver elastography, we can see that it has been stable throughout the period of utilization. So regarding our own experience in Saudi Arabia, here we report the two first patients that were actually treated with lumitabide in Saudi Arabia. The first patient was from National Guard Hospital in Riyadh, by our colleague, Dr. Ma'abbir. This is a young patient. Actually, she was on maximum tolerated statin, ezetimibe, evolocumab. In addition, she was diagnosed at age 14 with ischemic heart disease, and actually she went cabbage at that early age of life. She was later, when lumitabide was available, it was introduced to the patient, and we can see a significant reduction in the level of LDL, almost 82% using 40 milligrams of lumitabide. The medication was well tolerated without any side effects, and unfortunately we can see when the patient ran out of these medications for a period of time, we can see the rebound after lumitabide was stopped. On the same line, in the National Guard Hospital in Jeddah, again, we report a case of homozygous familial hypercholesterolemia. This patient actually was diagnosed phenotypically. The first patient had a genotypic assessment. However, for this patient, he was diagnosed phenotypically based on his phenotype in addition to the positive family history. He had a brother who died at an early age with ischemic heart disease, and actually he died after having his valvular heart replaced. So this patient, as we can see, on maximum doses of statin, ezetimibe, PCSK9, he was able to, his LDL level was lowered from 15 down to almost 7 millimole on only 10 milligrams. Unfortunately, we do not have a track of what was the effect of this later on, as this is the maximum dose he reached. After that, he was subjected to a surgery where unfortunately he didn't make it, similar to his brother, and he died. So if we look at the lumitabide over the past decade, we can see over the years some clinical trials, we can see real-world data, case series from various countries. Over these years, it has been shown that it is effective and safe. What about the ANGPTL3, the evinacumab inhibitor? As you know, it's a medication that works by inhibiting ANGPTL3. So once that is inhibited, the lipoprotein lipase and the endothelial lipase will be overactive, and for that we can see less of the VLDL remnants, and if that is taken up by the liver, then there would be less formation of LDL. So again, another mechanism of action, having lesser LDL formation. So it is LDL receptor independent. And it is effective, and as we can see that with this pivotal trial, there was almost a 50% reduction in the LDL cholesterol when compared to baseline. So just to complete the whole picture, it is very important to raise awareness about this disease, as we've seen that it carries a very high risk of morbidity and mortality. Most of those patients, unfortunately, they're not diagnosed, or they're misdiagnosed early in lives. For example, some of them are subjected to skin surgery. Others are going around seeking advice without really having their LDL. So if only their lipid profile was performed, then they can be actually diagnosed much early and treated much early. So pediatricians, endocrinologists, cardiologists, general practitioners, dermatologists, they all should be able to recognize this condition, diagnose it as early childhood, and treat the patient abruptly. And the diet plays an important role, as I mentioned, in this condition. So it's very important to put the patient on a low cholesterol diet, especially if this patient is on lumitabide, where this diet should be less than 20% of energy derived from fat. So it is very important to keep those patients on a low LDL, low fat diet. So just going over the last slide, and I think it's a very important slide. This is the HIC registry, where they have almost more than 750 patients registered from 38 countries. So this is a global registry. And if we look at the patients with homozygous familial hypercholesterolemia that are actually on statins, we can see that up to 92% of patients are on statins, 64% are on ezetimibe. If we look at apheresis, only 39% are on it, and this can be explained by the availability, as the issue is that it might not be available worldwide. However, if we look at lumitabide, it's only 8%, and if we look at evinacumab, it's even 2%. So very few patients actually are on aggressive therapies. And if we look at the lowest LDL cholesterols, we can see that there is a difference between the high income and non-high income countries. So for the non-high income countries, LDL level of 9.3, while for the high income countries, it's 3.9. Also, looking at the percentage of patients that at our goal, looking at the target of less than 1.8 and less than 2.5, again, in the non-high income countries, they're only 2.5%, and in the high income countries, they're 21%. So the take-home message from this presentation is that HoFH is characterized by an extremely high LDL cholesterol, more than 10 millimoles. We can refine the diagnosis by doing a genotype, but phenotype is probably the most important. HoFH is associated with a very high risk of cardiovascular events, even in young children. We should treat as early as possible once the patient is diagnosed. And in addition to the standard treatment, most cases will need, for sure, LDL receptor independent treatment, and long-term efficacy and safety for the metabolic data are available. And thank you for your attention.
Thank you, and appreciate your sticking around for hearing these wonderful symposia from our great sponsors. And I'm sure, Dr. Hawazin, you'll be here around to answer any questions you have. Moving on to our last symposium before our lunch break, I would like to present to you Dr. Rabi Hijazi. He's here on behalf of Servier Pharmaceutical to give his presentation regarding the management of dyslipidemia, strike early, strike strong. Dr. Rabi.
I think we're in business. So my presentation today is about management of dyslipidemia and how a powerful combination of ezetimibe and rosuvastatins can help us strike early and strike strong against cardiovascular disease. So for the next 10 to 15 minutes, I'll be sharing with you the latest guidelines, evidence, and some practical tips for your clinical practice. These are my financial disclosures. So as you can see from this slide, dyslipidemia is not just a local problem, it's actually a global phenomena. More than half of the adults in affluent regions of the world, like Northern Europe, Northern America, Asia Pacific, are affected by this condition. And the numbers, unfortunately, are rising year after year. So it is estimated that the number of prevalent cases of dyslipidemia worldwide will increase by about 12% from 2017 till 2027. This means millions and millions of additional patients will come to your practice that will need effective lipid-lowering strategies. I compare it honestly to a kind of an unwelcome subscription service, except that we did not sign up for it, and the renewal rate is unfortunately guaranteed. So this slide also highlights the clear and linear relationship between LDL cholesterol and atherosclerosis. As you can see, as LDL rises, so does the likelihood and the extent of atherosclerosis, starting from focal sites involving now multiple sites. So in summary, high LDLs means higher risk. Now this slide illustrates the relationship between the achieved LDL level and regression in coronary plaque. The key point from this study that a combination therapy involving a high-dose atorvastatin with ezetimibe showed the greatest reduction in the coronary plaque. And this translates into a beneficial effect in the arterial wall. Now, this is also a big idea kind of slide that tells you that the risk of cardiovascular disease does not only depend on the LDL level, it's also dependent on the cumulative exposure to high LDL. So it's very important to strike early, start treatment early, and also sustained control is very essential to minimize damage and risk. So earlier is better and longer is definitely better. Now this meta-analysis of 49 clinical trials involving more than 300,000 participants showed that for each 1 millimole per liter LDL reduction, there is a 23% reduction in major vascular events for statins. This benefit does not only involve statin, but it's also for non-statin-based therapy that involve upregulating the LDL receptor, as you saw from earlier presentation, like bempedoic acid, ezetimibe, and PCSK9 inhibitors. So it's no surprise that major organizations like the American Diabetes Association emphasize the role of statin therapy in primary prevention for patients with diabetes. So for people with diabetes age 40 to 75 without established cardiovascular disease, they recommend a moderate intensity statin in addition to dietary and lifestyle changes. Now, even for younger patients, aged 20 to 39 years of age with diabetes, with additional risk factors like smoking, they have proteinuria, they even have MASLD, hypertension, it's also reasonable to start statin therapy in addition to dietary and lifestyle therapy. Now, for people with diabetes age 40 to 75 years of age at higher cardiovascular risk, including those with one or more cardiovascular risk factor, it's recommended to use a high-intensity statin therapy in order to achieve an absolute LDL reduction of more than 50%, and also aiming at an LDL target of less than 70 milligram per deciliter or 1.8 millimole per liter. Now, for people with diabetes age 40 to 75 at higher cardiovascular risk that are unable to achieve this target on a maximally tolerated statin, then the use of ezetimibe and PCSK9 inhibitors are recommended. How about patients who are above the age of 75? The ADA states that it's reasonable to initiate moderate intensity statin therapy after discussing with the patient the potential benefits and risk in this category. As you know, in patients who are intolerant to statin therapy, a treatment with bempedoic acid now is available and is an alternative and attractive option. And as a reminder, as you know, statin therapy is generally contraindicated in pregnancy. The 2025 ESC and EAS guidelines takes it further, and they recommend progressively lower LDL targets as your cardiovascular risk increases. So for instance, if you have a patient with a low risk, like the patient here in yellow, the target is generally less than 116 milligram per deciliter. For high risk, it's less than 70. For very high risk, it's less than 55. And for those patients at extreme risk, it is less than 40 milligram per deciliter. And as Professor Carlos eloquently described to you, the patient at extreme risk are patient who has atherosclerosis in different vascular bed or patient who had recurrent ischemic vascular events. So in my practice as a diabetologist, most of my patients are gonna fall into the high, very high, and extreme risk categories. And a frequent problem I see in my practice, you know, I see patients coming in on atorvastatin 10 milligram daily or 20 milligram daily. Believe me, it's not gonna cut it, okay? We have to be more aggressive, more proactive in getting them to their recommended LDL goals. Now, these slides illustrate the average reduction in LDL with different pharmacological agents with proven cardiovascular benefits. So for instance, if you're using a moderate intensity statin, you expect a 30% lowering in LDL. Whereas if you use a high intensity statin, the reduction will be in the range of 50%. If you use ezetimibe or bempedoic acid on its own, you expect around the 20 to 25%. However, the nice thing, when you combine these agents, the reduction becomes much more substantial. So if you combine a high-intensity statin with ezetimibe, you expect a decrease in the range of 60%. Add to that combination a PCSK9 inhibitor, then you can see you can reduce it up to 80%. Now, if you throw everything you have under the sink, namely a high-intensity statin, bempedoic acid, ezetimibe, and PCSK9, you can reach close to 85 to 90% reduction in LDL. And believe me, I mean, you saw the guidelines earlier. I mean, to be able to achieve these ambitious LDL goals, most of the time we have to be using combination therapy. Now, these slides also illustrate the LDL lowering efficacy of different statins. So you see here, rosuvastatin 20 milligram on its own can reduce your LDL by about 50%, which is comparable to the highest dose of atorvastatin or simvastatin, 80 milligram. So for equivalent doses, rosuvastatin, delivers the greatest LDL reduction. So what is the mechanism of action of rosuvastatin and ezetimibe? And as you know, they work in synergy. So as you know, statins, they inhibit the HMG-CoA reductase activity in the liver, decrease cholesterol synthesis, and this ultimately leads to upregulation in the number and activity of the LDL receptor. Ezetimibe works in a different way. It works mostly on the intestine by blocking this MPC1L1 transporter, decreasing the intestinal absorption of cholesterol and reducing the cholesterol availability to the liver, and ultimately also upregulating the LDL receptors number and activity. This, in combination, leads to a very powerful reduction in the LDL concentration circulating in the blood. So what are the benefits of the combination versus statin monotherapy uptitration? And again, this slide shows you the potency and the efficacy of a combination therapy. As we said earlier, a high-intensity statin usually delivers, a 50% reduction in LDL concentration. However, when you combine it with ezetimibe, this is further amplified to 65% reduction. And this increase is not trivial. It's very clinically meaningful. It's really the difference between you achieving the LDL targets or missing it. This slide also shows the potency and efficacy of the combination therapy. So if you uptitrate a statin from 10 milligram all the way up to 80 milligram, you expect an incremental increase in LDL reduction of 5 to 6% with each dose increase. Whereas if you look here at the same slide, if you combine ezetimibe 10 milligram with a low-dose statin 10 milligram, you achieve immediately a 15 to 18% reduction in the LDL. So really, this simplifies the treatment, improves adherence for the patient, and it will allow them, to reach their target much faster. So guidelines are recommendation on the use of the statin-ezetimibe combination. Now, as with all chronic diseases, and I deal with a lot of chronic diseases, I treat diabetes, I treat hypertension, I treat gout, I treat also dyslipidemia. Adherence remains a major issue. So societies, they came up with several strategies for us to help us improve patients' adherence. And one of the most effective strategies is the use of a combination fixed-dose pill where available. Both the American and European guidelines also recommend the combination therapy. In the 2018 AHA-ACC guidelines, for patients who are unable to achieve their LDL goals despite being on a maximally tolerated statin, they recommend to add an ezetimibe or PCSK9 inhibitors. As for the European, in 2019 ESC-EAS guideline, they take it a step further and they gave it a class 1 recommendation. More importantly, they recommend ezetimibe. They position it even before PCSK9 inhibitor in terms of treatment escalation. And the message is clear. This also applies across all cardiovascular risk category. So this is not only for your high and very high risk patient who are unable to achieve LDL goal on a maximally tolerated statin. This also applies for your patient at low and moderate risk, emphasizing the utility of this combination therapy across all different cardiovascular risk and in management of dyslipidemia. Ladies and gentlemen, we are also witnessing a paradigm shift in management of dyslipidemia. Instead of adopting the traditional stepwise kind of approach, the EAS guidelines recommend upfront therapy with a combination high-dose statin and ezetimibe, especially in those individuals with high or very high risk categories. And as you can see, the proportion of patients at LDL goal went up by threefold with the combination therapy. This is a real-life retrospective cohort study from Italy, comparing patients who received ezetimibe and rosuvastatin as separate pills versus using the combination therapy. And as you can see, patients who use the combination therapy, they have higher rate of treatment adherence. Actually, in more than 75% of patients using the combination, more than 75 of them were adhered to the therapy in compared to their single pill combination peers. Now, talking about the acute coronary syndrome, and I think Professor Carlos did an eloquent, presentation on that. So the ESC emphasized the importance of initiation or continuation of high-dose statin and ezetimibe therapy in patients presenting with acute coronary syndromes even before they reach the cardiac cath lab. And in select patients who are deemed to be at very high risk, we have seen from our cardiology colleague initiation of PCSK9 in the acute care setting. And as Professor Carlos eloquently said, when you follow up these patients, please do not recheck their lipid profile 3 months after their event. Please make sure you recheck them in clinic 4 weeks after their event to make sure that their LDL is at goal and to see if we need to do any escalation in the therapy. Now, in terms of the trials comparing combination therapy to monotherapy, you can see from this meta-analysis of IROSET, Kim, and Young studies that the combination therapy is much more powerful than rosuvastatin monotherapy in achieving LDL goals across all spectrum. I'm going to also quickly mention the RACING trial, which is a large randomized, open-label, non-inferiority trial conducted in South Korea at 26 clinical sites and involving more than 3,700 patients with atherosclerotic cardiovascular disease who needs intensive lipid-lowering agents to achieve an LDL goal of less than 70. These patients were randomized into 2 groups, a moderate intensity statin plus ezetimibe, namely rosuvastatin 10 milligram with ezetimibe 10 milligram, whereas the other group received a high-intensity statin, namely rosuvastatin 20 milligram. And these patients were followed over a period of 3 years, looking at 3 major endpoints. The primary endpoint was a composite of cardiovascular deaths, major cardiovascular events, and a non-fatal stroke. The key secondary endpoint was the proportion of patients with an LDL cholesterol of less than 70 at 1 and 2 and 3 years mark. And the third safety endpoint was the discontinuation or dose reduction of study medication due to patient intolerance. So let's have a look at the results. And as you can see from this Kaplan-Meier curves here, that the combination therapy was not inferior to the high-intensity therapy in terms of the composite outcome over a period of 3 years. In addition, however, the power of the study that showed that a higher proportion of patients on the combination therapy were able to achieve an LDL concentration of less than 70, and they had a lower prevalence of discontinuation or dose reduction caused by intolerance to the study group. So in conclusion, what did we learn today? We learned that the reduction in LDL cholesterol level correlates linearly with plaque regression and improve long-term prognosis. We also learned that statins alone are usually not enough to achieve the ambitious and recommended LDL goals by the major societies around the world. We also learned that the addition of ezetimibe is very powerful and will give you a further reduction in LDL level and a consequent improvement in prognosis. And finally, a combination therapy with a high-intensity statin and ezetimibe in a single pill improves adherence. It's clinically very effective, and it's also clinically very practical in our patient population. Thank you so much.
Bismillah ar-Rahman ar-Rahim. My name is Abdrazak al-Madani. I'll be chairing this session with my colleagues, Dr. Raya al-Mazrou'i from United Arab Emirates and Dr. Salwar Aidarus from Saudi Arabia. Our first speaker is Professor Richard Kenton. Professor Richard Kenton is consultant endocrinologist in Newcastle and an honorary reader in reproductive endocrinology at Imperial College, London. He has been active in research for more than 30 years and with over 200 publications, principally relating to disorders of puberty and reproduction, but also in the area of calcium and bone mineral homeostasis. In the year 2000, Professor Kenton was awarded the Ralph Nobel Prize by Cambridge University, and in the year 2023, the Outstanding Clinical Practitioner Award by the Society for Endocrinology. He is an associate editor of Clinical Endocrinology, Endocrine Connections, and Reproduction and Fertility. Let's welcome Professor Richard Kenton.
So many thanks for that very generous introduction, and it's always a pleasure to be back here amongst friends and familiar faces. I feel the love. Thank you very much. So the topic is non-surgical management of parathyroid disease, and I've got no relevant disclosures. I'm going to skip through some of the earlier slides quite quickly because they will also feature in my second presentation today, in which I'll go into them in more detail. But in this presentation here, we'll do a refresher on PTH physiology, thinking about the non-surgical management of primary hyperparathyroidism, which I would describe as really making the best of a bad job because surgery really is the gold standard treatment. Thinking about what drugs we have available to manage primary hyperparathyroidism, what they're able to achieve, and what they cannot achieve. Uncertainties in the evidence base. And then thinking about moving on to hypoparathyroidism, which is something that's very much in our remit for us to look after, to give you my view on what should be patient-centered management. And then finally, the panic patients, the ones where you're called on Friday afternoon and someone's calcium has crashed after surgery, either Hungry bone disease after parathyroid surgery or acute hypocalcemia after laryngectomy or total thyroidectomy. And just to think about what can we do to identify those patients in advance, and so as far as possible to avoid getting that Friday afternoon call. So physiology of PTH, I said this will be repeated in my next presentation, so I'm going to go through reasonably quickly. Main action is to maintain concentrations of bone minerals, especially calcium, by promoting resorption of bone minerals by osteoclast from osteoid, by promoting active resorption of bone minerals in the distal convoluted tubule. Well, distal convoluted, this is the opposite here, where PTH pulls calcium out of bones and phosphate out of bones. PTH via VIT-D pulls calcium and phosphate out of the gut. But at the tubule, it's different. PTH pulls calcium out and into bloodstream and pushes phosphate out into the urine. And so there's direct action of PTH, and then there are the ones that via 1-alpha-hydroxylation of vitamin D. And the vitamin-dependent actions are GI absorption of bone minerals, mineralization of bone matrix or osteoid by activating osteoblasts and inhibiting osteoclasts. And just to remind you that a high phosphate promotes FGF23 secretion by osteocytes, which then promotes renal phosphate excretion, but also blocks the 1-alpha-hydroxylation effect. So what stimulate PTH secretion? Well, a low calcium, either from primary dietary deficiency or more commonly due to D deficiency, impaired hydroxylation in chronic kidney disease, or inhibition of osteoclast-mediated bone resorption by bisphosphonates or denosumab. And this effect is less sustained, though. Low phosphate, powerful stimulus to PTH, and also low 125 vitamin D calcitriol, a powerful stimulus to PTH secretion when it's low. What are the risk factors for low vit D? Well, low ultraviolet B exposure, malabsorptive surgery, older anticonvulsants, chronic kidney disease, celiac disease, bile salt sequestrants, pancreatic insufficiency. And also a mild to moderately low magnesium level promotes PTH secretion, whereas in contrast, severe magnesium depletion blunts the PTH response to a low calcium, which makes it very hard to correct hypocalcemia when the magnesium is very low. And this is the best figure I could find on looking at PTH action and control of secretion, but really we've gone through that already. So, pathological parathyroid disorders, medical management. So, primary hyperthyroidism and hypoparathyroidism. Primary hyperthyroidism, this is semi-autonomous PTH secretion. It's never completely autonomous because you can reduce that secretion with calcimimetics, with extra vitamin D. So it's semi-autonomous. And it can be caused either by a single parathyroid adenoma, which is around 80%, multiple adenomas, 10 to 15%, foregland hyperplasia, 5 to 15%, or parathyroid carcinoma, very rare, less than 1%. And really, the treatment is surgical, unless the patient refuses, they're unfit or frail. There's a kind of shared care decision-making in patients with milder symptoms and biochemistry, where they don't necessarily rule out surgery outright, but the patient says, you know, you need to persuade me a little bit more. My symptoms are mild, my calcium's not very high. Why don't we just hang on? Or patients with a high risk of relapse. So these would be patients with syndromic foregland hyperplasia, where really, what are you going to do? You take out 3 of the glands, the 4th gland's going to go overactive eventually. And really you're left with a choice of saying, well, should I take out 4 and make them hypoparathyroid? So think very carefully. And also if surgery's already failed and the patient says, just once enough, I'm not going to do it again. So the medical management of primary hyperthyroidism, usually it's filling the operational gap between diagnosis for the patient who can't have surgery or doesn't want to have surgery. But it can also act as a bridge to surgery by improving a patient's functional status and well-being in the interim. So maybe the first time the patient meets the anaesthetist, they go, no. But actually, after some specific medical management, when they meet the patient again, they may say, yeah, you know, they're looking a bit better, really. So medical management, it's either in patients who really are not going to go for surgery or as a bridging therapy in those who are considering surgery. Hypoparathyroidism, this is now considered to be permanent if it was congenital in the first place or if it was more than 1 year since it was acquired post-operatively. The guidelines have changed. Previously, it was 6 months. 6 months is useful for surgical audit purposes. But actually, in reality, 7.5% of patients are found to recover PTH function between 6 and 12 months. But there's an important tough love effect. What you really want is an endocrine nurse who gives patients the tough love to kind of try and persuade them to come off the calcium. Because many patients have thyroid surgery, have got post-op hypocalcemia, which may or may not be permanent, and they're just dumped on vast amount of calcium by other surgeons. Bye. And then months or years later, you may be having to unpick that. And having a nurse who's prepared to do the tough love, so yes, no, you got some tingling, but try and reduce a bit more, may make all the difference between getting the patient off treatment and them remaining on it. But otherwise, If it's permanent hypoparathyroidism, you're looking at lifelong medical management, and that requires significant patient commitment. My colleague Andrew Dwyer, professor of endocrine nursing at Boston College, says for a patient with chronic disease, such as diabetes or hypoparathyroidism, they're actually delivering about 80% of their medical care. They're going to appointments, they're getting blood tests done, they're getting their prescriptions, they're taking their medication, they're reading letters, and it's important that they're fully engaged. So, primary hypoparathyroidism, what are the aims of medical management? The first is to mitigate the symptoms of hypercalcemia. The second is to mitigate the symptoms of hyperparathyroidism. So hypercalcemia, thirst, polyuria, constipation, nausea, abdominal pain, dyspepsia, fatigue, brain fog in some cases. Hyperparathyroidism, musculoskeletal aches and pains, fatigue, weakness, sweating, flushing. Hair loss isn't in the textbooks, but it's what patients complain of quite a lot in the patient support groups. You want to preserve bone density and protect against osteoporosis and fractures. You want to prevent or minimize kidney stone formation and preserve renal function. And you want to minimize the cardiovascular risk. Hyperparathyroidism, whether it's primary or secondary, has effects on the cardiovascular system that are unfavorable. Hypercalcemia, what can we do? Simple stuff: maintain hydration, avoid diuretics. What you shouldn't do is restrict dietary calcium excretion, because that can actually increase PTH levels and accelerate disease progression. We have oral senocalcet, a calciomimetic, at a dose of between 30 and 270 milligram a day, either once, twice, or 3 times daily. So this, if it's tolerated, that'll achieve a reduction in 100% of patients' reduction in calcium level. And in 75%, it will normalize the adjusted calcium level. And that effect is maintained long-term, more than 5 years, and that will achieve resolution or reduction in hypercalcemic symptoms. So that we can manage medically. But it's limited by dose-dependent side effects, nausea, vomiting, and paresthesia. Take it with food. Take it the way you take metformin, last mouthful of food. But it's got no effect on bone turnover markers, no effect on bone density, no effect on fracture risk. And broadly, no effect on blood pressure, renal function, urinary calcium, or the incidence of kidney stones. And the cost is just under $1 US dollar per 60 milligram tablet. So it's not cheap. Okay, that's one treatment considered. Another treatment, supplementation with vitamin D, cholecalciferol, between 1 and 2,800 units daily. So that achieves up to 50% reduction in PTH levels, depending on the severity of baseline deficiency. So that's good. There is no impact on serum or urine calcium or the incidence of kidney stones. It will reduce bone turnover, and the bone density will increase quite significantly at all sites. So this is something that can improve bone density in a way that senocalcet can't. But unfortunately, there are no data on fracture prevention, impact on aches and pains, or impact on quality of life. Senocalcet initially achieves a 30 to 40% reduction in PTH levels, but in the long term, it's down to about 8 to 15%. And it's unclear whether symptoms of PTH excess are also mitigated. And it's unclear whether, in doing so, it reduces the adverse cardiovascular impact of hyperparathyroidism. So, what about another aim? Preserve bone density and prevent osteoporosis and fracture. Supplementation with vitamin D. We know it's good for bone density, bone turnover, no idea about fracture. Oral senocalcet, no effect on any bone parameters or fracture risk. HRT in postmenopausal females. And actually, we know that there are RCT data, not in primary para, but in the general population, showing that HRT protects against osteoporosis and fractures to the same extent, same effectiveness as denosumab or bisphosphonates, and in a vastly cheaper manner. In primary para, it does not cause any change in PTH or calcium levels. It does reduce urine calcium excretion in a way that bisphosphonates and denosumab don't, but there are no data on kidney stones. I said it reduces bone turnover and improves bone density across all sites, but no data on fracture prevention specifically in the area of primary para, whereas there is in the generality of postmenopausal females. Then the anti-resorptives, bisphosphonates and denosumab, either alone or combined with cinacalcet. So they initially caused an increase in PTH, and denosumab, there's also a fall in calcium. But in the medium to long term, there are no changes. Bone turnover is reduced, and there's improved bone density at lumbar spine and hip, similar to that achieved by HRT. There is no effect on urine calcium excretion, so in that sense, it's inferior to HRT. In primary parathyroidism, there are no RCT data on fracture prevention, which is why, but it's generally recommended in guidance. However, I would signpost you to big data studies from Southern California, Kaiser Permanente, a massive database, nearly 11,000 patients with primary parathyroidism, where they found an increased risk of fracture with bisphosphonates compared to parathyroidectomy or no treatment. And it's easy to say, well, it's not an RCT, and, well, probably those with worse bone density in the first place were given a bisphosphonate. But actually, if you look at the data very carefully, the groups were actually fairly well matched. So if you want to prescribe bisphosphonates in patients with primary parathyroidism, don't imagine that it'll improve their bone density. Don't imagine it'll necessarily reduce their fracture risk. And there's the potential it might even increase their fracture risk. So again, when you're having that first discussion with a patient about whether to have surgery or not, I wouldn't big up medical therapy as a means of avoiding fracture. So what about preventing kidney stones and preserving renal function? Well, maintaining hydration, very sensible, but no direct evidence of benefit in primary para. Supplementation with vitamin D, neutral. Oral cinacalcet, neutral. HRT, no data, but reduced urine calcium. Anti-resorptives, neutral. Reducing the risk of cardiovascular disease. We know that both primary and secondary hyperparathyroidism are linked to an increase of total cardiovascular and cerebrovascular death. And this has a much closer relationship to PTH level than the calcium level. We know that parathyroidectomy reduces total deaths, cardiovascular deaths, and cardiovascular risk. But there are no medical interventions that are proven to achieve this in primary para. But it's sensible to consider supplementation with D to reduce PTH levels, restriction of dietary salt to reduce blood pressure and renin, tight control of blood pressure with vasodilators, and active management of lipids, fasting, glucose, and HbA1c. So I'm now going to move on to the patient-centered management of hyperparathyroidism, and I'm going to refer to two studies. So one is the ESC draft clinical practice guideline on hyperparathyroidism, which is out for review. And the second is my extensive personal experience, and particularly a study I did along with my friend in the audience, Dr. Ahmed Al-Sharefi, which, even though it's not an RCT, I know that study was read by the authors of the European guidance, and I know that it influenced their considerations, even though they couldn't quote it. So, the elephant in the room. Due to the lack of PTH action on renal tubules, restoring full normocalcemia in hyperparathyroidism will result in hypercalciuria and a high risk of nephrocalcinosis, kidney stones, and chronic kidney disease. Therefore, you'll need to maintain the serum calcium levels within the lower part, or even slightly below the usual reference range. Now, historically, hyperparathyroidism was the only hormone deficiency syndrome not treated by replacing the missing hormone. PTH184 and NATPARA was withdrawn after a few years as not being commercially viable. We do have teriparatide at PTH134, which is only licensed for osteoporosis, but its half-life is only about 1 hour. Onset of calcific action about 2 hours after injection, peak at 4 to 6 hours, and returning to baseline within 16 to 24 hours. It's unlicensed for hyperparathyroidism, but there are some clinical experience and numerous unsuccessful studies of daily dosing. If you're going to use it, then your minimum frequency is twice daily, probably even 3 times daily, and there are studies of it being used as a continuous subcut infusion. It allows you to reduce oral supplements, it allows you to reduce calciuria, but usually not a complete substitution of oral calcium salts and activate D. Coming up soon, in fact available in some countries, is extended action PTH134, either pegylated or transcon. And they have good RCT data, and they should be coming soon. And these can achieve complete substitution of oral supplements if so desired, rather than just a reduction in dose. And there's also the potential to actually achieve the patient's pre-morted serum calcium. If the patient's serum calcium was 2.45 prior to thyroidectomy, well, actually you can aim for that safely if you replace parathyroid hormone in a manner you couldn't do with activated vitamin D and oral calcium salts. European Society of Endocrinology endorses parathyroid hormone replacement for those patients with brittle calcium levels, kidney stones, hypercalciuria, reduced EGFR, or reduced quality of life. So what do the patients themselves tell us? And Ahmed did a fantastic Europe-wide patient survey that was coordinated with the patient support group. So we know that oral calcium salts are a great first-line treatment for new-onset hypocalcemia, but patients really hate taking high-dose calcium salts. And 36% become quiet quitters. They just stop taking them. They may not tell their doctors. They complain of dyspepsia, constipation, tablet burden, and the rapid onset of effect and terrible taste. And actually, it's not such a good idea from the clinical perspective either. So if you want to measure urine calcium in a patient on oral calcium supplements, you have to do the 24-hour calcium collection, which is a real pain. If you do spot urine calcium creatinines, the levels may vary quite a lot depending on the relationship between your last calcium dose. 24-hour urine collections, they're a big pain. And potentially, there's a risk of additional renal harm arising from transient high peak levels. And remember those studies from Bolland in New Zealand looking at calcium vitamin D in the general population show actually an increased cardiovascular risk. And actually, for those patients with adequate dietary calcium anyway, what is the purpose exactly of bunging in even more? And so we found in our survey that those patients taking oral calcium salts were 3 times more likely to have had kidney stones or hypercalcemic symptoms. And they also experienced more hospital admissions with both hypercalcemia and especially hypocalcemia. So in this graph, you see in the orange, not taking calcium, and in the blue, whilst taking calcium. And some of these patients were in both groups. They reported their experiences while they were taking it and after they stopped it. And we see the major worsening of symptoms. We see particularly that hypocalcemic admissions were much more common in patients taking calcium. It may seem like a paradox, but you can imagine if someone has a high tablet burden, taking all this calcium all the time, eventually they can't stand it, they miss out, boom, into hospital, hypocalcemia. So the treatment that we think is doing patients good may actually be doing them harm. And really 65% of these patients had been hypoparathyroid for longer than 5 years, some of them for as long as 20 years, and our N number was 330. So this is the Newcastle protocol for treating hypoparathyroidism, and I'm pleased to see that a lot of it was actually adopted in the draft European Society guidance. And I call it KISS, keep it simple, stupid. 25 hydroxy-D levels, make sure that in the Malibu beach range, at least 75, maybe even 100 to 150 nanomole per liter, just so you can get over any impairment of 1-alpha hydroxylation through lack of vitamin D. And in the UK, at high northern latitudes, every single patient will require supplementation to achieve those levels. And the doses will range from about 800 to up to 3,000 units, 20 to 75 microgram daily. If you're post-bariatric surgery or with pancreatic insufficiency, you'll need a whole lot more, 4,000 to 5,000 units a day. Second lesson is avoid the proton pump inhibitor doom loop, which runs a bit like this. You take your oral calcium, you get dyspepsia, you put on a PPI, the PPI crashes your magnesium level, your serum calcium falls, you give them more oral calcium, and repeat, and feel even worse. So whatever it takes, avoid PPIs, use high-dose H2 blocker, use oral antacids, and give sensible doses of calcium, or even better, don't give it at all. So alpha-calcitrol or calcitriol, once or twice daily, aiming to achieve adjusted calcium 2.1 to 2.3. We do not give oral calcium salts in Newcastle. Aim to keep your morning urine calcium creatinine ratio, that's the overnight sample, under 0.5. And this, we know from the Newcastle stone population, kidney stone population, that keeping that ratio below 0.5 gives you a much lower risk of kidney stones. If you're hypertensive, which a lot of the older patients are, ensure that a low-dose thiazide is in the mix. Say bendrofluozide 1.25 to 2.5 milligram daily. We don't put in thiazides when someone's normotensive, but if someone's even remotely hypertensive, we make sure thiazide's in there. If someone's taking other antihypertensive drugs, we take them down and put in a thiazide. And that creates a bigger window of opportunity. It allows us to push the calcium level a bit higher whilst maintaining a urine calcium creatinine that's in the safe range. And these were the data of the last time we analyzed the cohort of patients treated without oral calcium. And as I said, we achieved sensible calcium levels. Renal function was pretty good. Vitamin D levels were in target. The median was 118, minimum 78. And the D3 dose was mean about 1,500 per day, but it ranged from 800 to 2,800. So we know that this treatment works and it's safe. So we're going to begin to wrap up now, so to leave us more time for discussion, but the ESC guidance has been updated since 2015, and what does it propose by comparison? It says maintain a normal serum 25-OHD level. I think previously they said keep it above 100, above 50, and now they're saying keep it normal. For me, this does not withstand logical analysis. We know there's all kinds of controversies as to what should be a healthy vitamin D level in the normal population. You know, should it be 50, 70? This isn't a normal population. This is an abnormal population. This is the population that cannot fully activate vitamin D. So if there's any doubt, put the VD level high. As I said, in the Malibu Beach range or Bondi Beach range, at least above 75, maybe above 100 nanomole per litre. ESC now says, don't routinely supplement calcium unless the estimated dietary intake is under 800 to 1,000 milligrams daily. However, all bariatric patients are presumed to have dietary calcium deficiency. And also, don't give more than 500 milligrams of oral calcium at a time. If you're giving additional doses, they need to be distributed across the day. Whereas in the community, there are patients taking like up to 6 tablets all at once. It's barbaric. And more importantly, ensure a normal magnesium level, although they're not quite so specific as to how we should do that. And they mentioned thiazides as an adjunctive treatment for hypocalcemia. So it's nice to know that what we did in Newcastle for many years is now forms part of the European Society of Endocrinology recommendations. Now, the Friday afternoon patient. Let's think what patient might be at highest risk of refractory surgical hypocalcemia after laryngectomy or thyroid surgery, or hungry bone disease post-parathyroidectomy. Laryngectomy for cancer, much higher risk than thyroid goiters, because the nutritional status is often very poor, and they very rarely get outdoors, so they're at much higher risk of having underlying more severe D deficiency. Any patient who's had malabsorptive bariatric surgery, they will tend to have mineral and vitamin D deficiencies with secondary hyperparathyroidism. The bariatric surgeons rarely give them enough supplements. And they may get bacterial overgrowth of redundant bowel loops. Now, I don't know why, but there's something about having bacterial overgrowth that just literally churns through your vitamin D and makes it almost impossible to supplement even at high dose orally. And you may need to treat these patients with a with an enteric, non-absorbed antibiotic, such as rifaximin, to zap the bacterial overgrowth. Patient with hypomagnesemia, secondary proton pump inhibitors, alcohol abuse, malnutrition. Patient with pancreatic insufficiency, or those on bile acid sequestrant therapy. Along with bile acids, vitamin D and thyroid hormones undergo an enterohepatic circulation into the bile, into the gut, reabsorbed again. Cholesevelam or cholestyramine will break that. So patients on thyroxine will often need to increase their dose of oral thyroxine, and patients who may have been vitamin D depleted in the first place may become severely deficient and require much higher dose supplementation on these drugs. And of course, patients with kind of behavioral or cultural hypovitaminosis D. Vegan diet, no meat or dairy, or all of the above. So try and get your surgeon prepared in advance. So this patient is likely to be one of your Friday afternoon nightmares. Let's see what we can do. What can I do to help my surgeon address these factors before the patient goes for surgery? So conclusions, for primary hyperthyroidism, there are major limits to what physicians can achieve once parathyroidectomy has been ruled out. So think very, very, very carefully before ruling out parathyroidectomy. On the other hand, for patients with hypoparathyroidism, there's a huge amount physicians can do to improve patient care by consigning historic regimens to the dustbin of history. Reduce the tablet burden, reduce complications, reduce hospitalization, reduce symptom burden, better biochemical control, improve quality of life. So thank you very much for your attention, and I'm very happy to take some questions. Yes. Questions at the end, okay.
Thank you very much, Dr. Quentin, for this elegant presentation, and it has, Karim, very important practical point about the management of parathyroid disorder. So we'll leave the question at the end of the session, and now it gives me a pleasure to introduce Professor Sadat Ali, who is a well-known and distinguished orthopedic surgeon from Saudi Arabia, and he works as well in Bahrain. He's a leading authority in regenerative medicine. Dr. Sadat, or Professor Sadat, is board certified in regenerative medicine from the United States. He has been recognized among the top 2% of the world scientists by Stanford University since 2019, and was nominated for the King Faisal International Prize for Medicine for his pioneering work in bone biology and osteoporosis. With over 200 scientific publications and decades of contribution to the orthopedic research and education, he continues to lead the innovative work in bone regeneration and stem cell therapy. Today, he will be sharing his insight on sequential therapy in osteoporosis, an evolving and highly relevant area that bridges science and clinical practice for better patient outcome. So please share me welcoming the Professor Sadat.
Good afternoon, ladies and gentlemen. Thank you much, Dr. Salwa. It's a pleasure to be here. It's very unusual for a surgeon to be among physicians, because always physicians tell the surgeon that we are wrong. But for a change, let us listen what the surgeon has to say about a disease which involves both the surgeons, because the physicians make the mistake and the surgeons fix it. I have no conflict of interest for this presentation. The key statement for this presentation is based on my long, about 35 years experience of fixing hip fractures because of lack of osteoporosis medication in proper time. The concepts which I am going to present today might as well improve the patient outcomes in the future to come. Lastly, 30% of the people who are sitting in the room will have to have osteoporotic treatment in the next 20 years. if they are around 30 years. Before I go on to the sequential therapy, which is really important aspect, I just want to lay down some foundations so that we understand the treatment itself, what we are lacking, how we can improve the patient quality of life over time. Osteoporosis is an incurable disease without treatment. If you don't treat them properly, they will suffer, and then in the end, they will have a fragility fracture. For us Muslims, we knew long time back over the years that as we grow old, the bones will become weaker. But the WHO took so long time in 1994 to describe osteoporosis on the base of the T-score. I'm sure everybody is aware of the different T-scores where osteopenia and osteoporosis is given. Not moving forward. Okay. Women particularly have a high prevalence of osteoporosis, which is 30% around the world. As they reach the age of 70 years, approximately 42% of them will have osteoporosis. If not treated, they will end up in fragility fractures. Do we have a problem in the Gulf? That's what we need to know, because we are talking about GCC. This was a meta-analysis which was done some time back, involving about 10 different publications, 10 different countries. Average osteoporosis in the region for women over 50 years of age is about 29%. Now coming to the fragility fracture of the femur, which we are more concerned about, which causes about 30% of the mortality within the first year of fixation. Here we found that the number of fractures were about 4.41 per 1,000 women over the age of 50 years. Now compared to this, the Middle East, if it is 4.4 per 1,000, Scandinavian countries, the incidence of fragility fracture is over 34 per 1,000. Why the difference? Now, the most important factor here is the genetic influence, which the genes which the Middle Eastern population is carrying is protective of a fracture. There was only one study which came back from our institution in 2012. We found that the particular genes like LR5 and LOX15 protect, even though they have osteoporosis, but they have less number of fragility fractures. And unfortunately, nobody looked into this genetic influence in the Middle East. Facts to prevent fragility fractures is a proper treatment, closing the gap in the treatment, and monitoring. I will take the third one first. The DEXA and FRAX only predict fracture a 10-year period for about in 70% of the cases. Whereas a recent study from our, again, meta-analysis from our institution showed that if you use the AI technology, it predicts femoral fractures within the next 2 years in 93% of the population. So what we need to do is we need to change the technology from FRAX to DEXA in the coming years. Now, the gap in the treatment is wide. It's universal. This is the European study we showed. The gap goes up to 71% in various countries. Like Switzerland, if you see, it is 76%. Now, a patient coming to the emergency room is treated from headache to MI or abdominal pain, but a patient coming with a fracture to the emergency room is left alone without the proper treatment. Now, in 2014, we assessed in the University Hospital in Khobar that our gap was about 83%. Patients were not getting treated after a fragility fracture. Then the orthopedic department took over the management of osteoporosis. And then in 5 years, we brought the gap back to about 12%. So if at the present time, if fracture liaison service is introduced in all the hospitals, probably that's where you will reach the gap reduced to about 10 to 12%. Now, this is my own feeling, is osteoporosis management should not be free for all. At present, everybody is treating osteoporosis, right from a GP to a rheumatologist and endocrinologist, neurosurgeons and all that. I think the osteoporosis management requires a real dedication and time to be given to the patient. And I believe that the physicians and surgeons have failed in preventing the first fracture and preventing the second fracture as well. Now, the principles of management depends on the changes in the lifestyle and the medications. And we have to see the patient as a whole, as a holistic approach, not only on treating osteoporosis itself. I feel that we are sitting on a tip of the iceberg when we see an osteoporotic patient. Now, patients rarely get a fragility fracture if they don't fall. Now, in our practice, we have seen that 66% of the patients who fall and break a bone have osteoarthritis of the knee. 30% of them have some neurological disorder. They cannot walk properly. They cannot have proper neurovascular balances, so they fall. So what we need to do is whenever we see a patient with a fragility fracture, we have to assess the other diseases which they are having. Now this is one of the patients which I want to show how osteoporosis is mismanaged. 63-year-old female came for a total knee replacement on one side. The left side, at the time of replacement done, they found a crack in the distal condyle. This was fixed. When this plate was removed, the middle shaft of the femur cracked. At this patient, at this time, the surgeon were thinking that because of she was not taking the oral bisphosphonates, they changed from oral bisphosphonate to IV bisphosphonate. IV was given. Very soon, she cracked the proximal femur, the same leg. This was also fixed, and the surgeon were happy, the physician was happy, and then very soon she cracked the neck of femur. So this patient was totally mismanaged by both the surgeons and the physicians. In the end, the patient died in the hospital. So this should not be the routine. This should not be even a single case in a given hospital. For any osteoporosis treatment, even for sequential therapy, there has to be some prerequisites. I want you to go back to this Time magazine article of 2010, which was given by a writer who wrote that how the first 9 months shape the rest of your life. Now, why it was important that even the intrauterine life of a baby is very important to develop the different organs of the body. Vitamin D receptors have been found in brain, kidneys, and all organs. Most of the diseases, even in the adult life, which the people are suffering, I believe that this could be what has happened during the intrauterine life. Now, one of my patients is this young lady had a normal vitamin D. This was an 8th month. What you see is the length of the femur. Now, this is another lady who has got hypovitaminosis D, severe osteomalacia. You can see the ultrasound, the femur is already bending in a baby. So vitamin D is quite important. I appreciate what Dr. Quinton laid down, the importance of vitamin D. Now, apart from that, the second thing important is how much vitamin D to be given. That is a different subject which I will not go into. We have done enough research on that. We found out that the vitamin D, one dose is not enough for everybody. We found that the vitamin D dosage should be based on the per kg body weight, a BMI, and our level in Saudi population, we found that 125 IU per kg body is a very ideal to maintain enough vitamin D. Now, exercise is important. There are different exercises which can be done at home. We don't prefer gym because women going to the gym are sustaining more injuries in the gym than at home. Now, pharmacologic therapy, most of the studies do not put estrogen at the top. I have put it as US FDA has written a long time back as prevention only. Now, I have kept a box of the gift on the right side, which I'll open at the end of the presentation. Now, drug therapy for osteoporosis, sequential, probably requires for about 30 years, right, postmenopausal. None of the drugs can be taken for a long period of time except bisphosphonates. Now, the GCC guidelines came up in 2020, which was just like what we see the recommendation of the Endocrine Society of North America or Canada or International Osteoporosis Foundation. But I have some concerns about this. I'll come back to you in a minute. Now, why sequential therapy is important? Drugs particularly like DMAB or teriparatide or romosumab, when they are discontinued, they have a rebound mechanism which they gain, loss of bone happens, whichever it was gained. Or except the bisphosphonates, which does not allow the bone loss to occur. Now, there are 5 situations where sequential therapy becomes important. Because the limited recommendation treatment duration. Some drugs like baloperitide or teriparatide cannot be given more than 2 years. Secondly, the romosumab is only for 1 year. Some of the drugs, even though patients are taking, there is an inadequate response of the drug. Fracture risk reduction is important when you are giving. You are giving the treatment because you want the fracture not to happen. Even in treatment, you are giving the treatment properly, patients will suffer a fracture. Here it becomes important of sequential therapy. Lastly, what is important is you have to have, I believe, individualized treatment for each patient. Again, one patient will take some drugs which may not suit her, so that you have to change. You can't prescribe one bisphosphonate to every patient you see. Now, sequential therapy becomes important, what to use first and what to follow later. Now, in my group, what we believe is that we can divide this into 3 groups of patients. First, between 56 to 65 years, that's the first 10 years postmenopausal. It depends on area-wise, but what we have seen in most of the Middle Eastern countries, menopause happens somewhere about 54 to 55 years of age. Second group comes between 66 to 75, the last is over 75 years of age. Now, between this first group, the SERMs, oral bisphosphonates, and IV bisphosphonate is recommended. And we know all of us that this is the standard treatment. But I want to raise these 2 concepts of the HRT, and this last one is how we can postpone the menopause. If we combine the 3 drugs between SERMs, alendronate, and HRT, the only issue comes for HRT is the breast cancer. The second thing between the SERMs and the alendronate could be the atypical femoral fracture and osteonecrosis of the jaw, which are very serious issues. At least for atypical femoral fracture, we can fix. But as of now, we don't have any standard treatment for osteonecrosis of the jaw, and patients keep suffering. Now, conjugated estrogen was used in the famous WHI study by Manson and group. And the reason why the plug was pulled out very early from this study was because they found that the breast cancer and the other issues were very common. If you look into their study, they found that those women who have used estrogen between 50 to 59 years compared to placebo, they have 19 fewer cases than the placebo group. Then why this group should not have estrogen therapy? whereas the combination between the estrogen and the progesterone had 19 more cases. Now, this was the study, the GCC guidelines, which came in 2020, and I was surprised to see 4 months down the line, the same group, half of the authors suggested in December, the other study came back in somewhere in June, half of the group wrote that the HRT should be the target in the first 10 years of postmenopause. So I did not agree from between the first and the second, which is right, should be HRT was there in the first GCC guidelines. It's not there. Now, Stevenson from the advisory board to the British Menopause Society, published in 2023, suggested again the hormone replacement estrogen to be on the top of the line, the first 10 years post-menopause. Now, at present, the amount of estrogen, which was 0.625, has been reduced to 0.3 milligrams, and even a dermal dose reduces much more. So if you are giving this in the first 10 years post-menopause, this is much safer, including the risk of breast cancer. But again, whenever we are giving this estrogen or HRT, we have to be sure that the patients, there is no family history of breast cancer, and the follow-up of the stroke and the other issues to be monitored for DVT. This is a small study. I want to show it to you between placebo and HRT. The amount of bone gain by estrogen in the first 10 years post-menopause is much more better than any other pharmacotherapy which is available. Same, it goes back, this is between progesterone combined and the estrogen alone. Now, the dermal, transdermal and oral, transdermal is much better than the oral combination. This concept of postmenopausal to postpone the menopause came very recently. But the infertility people, IVF people, started looking into it way back in 1999. What they were doing was they used to take out the ovaries of patients who were suffering with cancer. They used to cryopreserve the ovaries. And then once they are in full remission, they used to transplant the section of the ovaries in the abdominal wall, and there the ovary used to function as normally before. A recent article came from the School of Medicine, Yale University. I think we should all read about it, that how ovarian tissue freezing could prevent menopause, possibly forever. It's a fantastic article, should be read by everybody. Right now, the recent literature suggests that ovarian tissue freezing success is about 80%. So in case if somebody wants to postpone the menopause and reduce the number of years they want to take the osteoporotic medication with improved quality of life, this might be an option. Now, once the 10 years is gone, whether should we put it to anabolics or DMAB? The issue is that if you use anabolics, the much better chances of regaining the bone. The rheumatism complications, we know it's a risk of myocardial infarction. It should be used for only 1 year. Anabolic first and DMAB by teriparatide, followed by DMAB. Again, the bone gain is much better than the other group. So once we have used the 2 years of DMAB, the anabolic, the best treatment is for DMAB to continue for the number of years. Now, I have seen many patients with the rheumatologists using the immunotherapy and at the same time using the DMAB. Unfortunately, it should not be done in this way because both the chances of having infection is very high. Atypical fractures in ONG is common, but at the same time, second cancer, we have to understand that patient in phase 3 trials of DMAB, what has happened that when they were using 60 milligrams versus 120 milligrams, they found the second cancers were quite high in the group of so we have to have the follow-up. So once we finish 10 years of DMAP, we have only other options is residronate and SERMs, and follow that till the rest of the patient's life. Drug holiday is an issue which we have to decide patient to patient, but again, even in drug holiday, we can have at least 40% of the fractures during that period of time. Now, this was an article I wrote recently about in MENA region. In the first group, low-risk patient, we believe estrogen, post-menopause, or oral bisphosphonate has to be used. But again, if there is a high risk, come back to the anabolic agents. And this has to continue till the patient have a good amount of bone gain and continues to have a good life. Now, I'll take about 1 minute or so if Dr. Salwa agrees with me. I promise you that I'll open a box for you. Probably, I believe in the next 10 years or so, these medications will be obsolete. I'll tell you in a minute. The stem cell therapy is coming. This is the study which we did, animal studies. We have found that on the left side here, ovarectomy-induced rats, we have used osteoblasts as the treatment, and we found that the bone gain was far superior than the control group. This is another study, control versus osteoblast group. We have seen how it is. Now, this is how the high-resolution quantitative CT analyzed the control versus osteoblast group. This was repeated in rabbits. The same story goes that the bone gain is much more higher. This is the spine. A recent study from China came with meta-analysis of 355 animals, showed that the stem cell therapy might be the answer for the future studies. The core message and conclusion is that therapy is very strategic, long-term approach to manage osteoporosis correctly. If we practice, it is cost-effective for the healthcare economics in reducing fracture risk and also to adapt patient needs over time. The third thing is that it's important that we have to have a country-specific management guidelines. GCC is one country where there are 6 countries involved, but unfortunately, some of the drugs may not be available in every country. This is what I try to find out. I stand corrected that teriparatide and Evenity is not available in Bahrain. In Kuwait, Evenity is not available. In Oman, both are not available, anabolics. In Qatar, the romosumab is available off the shelf. You have to place an order and then you get the supply. Whereas in Saudi Arabia and UAE, everything is available. So if a patient you are prescribing anabolic in Bahrain, I don't know how they can get it. So one country-specific guidelines has to be issued so that at least the patient are in a proper treatment is given to them. Thank you very much.
Thank you very much, Professor Sadat, for this elegant presentation and this you shed a light of a potential stem cell role in the management of osteoporosis. So we'll back to Professor Quinton, and he already was introduced, and he will continue again on the parathyroid disorder. So welcome again.
So many thanks, and I was actually humbled by that talk from Professor Sadat, because we used to make jokes about orthopedic surgeons, like, what do you call a holistic orthopedic surgeon? Someone who looks at the whole bone, not just the fracture. But that was an amazing holistic presentation, and massive respect. Thank you. So, normocalcemic hyperparathyroidism. I'm just going to go through some basic physiology first. So we measure intact PTH now, which is the full-length molecule 184, although 134 is the active moiety. You can measure PTH in both serum or EDTA plasma, purple top, full blood count top, HbA1c tube. Now, plasma values can be up 20% lower than serum values from the same sample. We need to know that. Serum samples in some ways are more convenient because actually it just requires the standard tube. How many times in diabetes clinic we're looking for the HbA1c result and it says no EDTA sample received in the lab. However, the serum samples require rapid separation after venipuncture. And so that's a problem if the blood sampling is done distant from the central lab. So really, if you can get EDTA plasma, that's preferred because it limits degradation of intact PTH, gives more reliable results, and actually allows a reasonable time frame for samples to reach the central lab from more distant clinics and sites. So, this presentation, we assume the patient has a high plasma PTH and a normal serum calcium. But within that, there are various different forms. So we need to know, is the hyperparathyroidism, is it entirely reactive, secondary, or is it even partly autonomous, we call primary? How can we distinguish between the two varieties, and does it even matter? What's the evidence for autonomous or semi-autonomous normocalcemic primary hyperparathyroidism as a relevant clinical entity? Well, I'm going to review PTH physiology to test whether the concept stands up in principle, and I'm also going to review the literature for normocalcemic primary hyperparathyroidism. And I'll present a clinical case from my own medical malpractice files, a case for which I was an expert witness, and to finally, in the end, give you a pragmatic management strategy for when you might encounter these patients. So PTH, its aim is to maintain concentrations of bone minerals, particularly calcium, by promoting resorption of bone minerals from the osteoid, performed by osteoclasts, to cause active calcium reabsorption and phosphate excretion in the distal renal tubules, to promote 1-alpha hydroxylation of vitamin D, leading to vitamin D-dependent actions, so GI absorption of bone minerals, mineralization of bone matrix or osteoid by activating osteoblasts and inhibiting osteoclasts. And what are the stimuli to physiologic PTH excretion? A low calcium, such as from primary dietary deficiency, or more commonly due to D deficiency, or impaired dehydroxylation, as in CKD. You can also get a low calcium when there's been acute treatment with bisphosphonates or denosumab, particularly in a vitamin D deficient patient. There's a very wide difference in set point for PTH hypersecretion with vitamin D level. Some patients can go very low in vitamin D and not mount much of a PTH response. Other people, you really do need to get their PTH levels way up above 100 nanomole per liter, maybe sort of 60 of your American units, in order to normalize the PTH level. That may partly reflect dietary calcium. It likely also reflects genetic factors. A low phosphate will stimulate PTH secretion at sort of a low calcitriol level, and these will be the risk factors for having a low calcitriol level. And again, a mild to moderate low magnesium promotes PTH secretion, but a very low magnesium level blunts it. It's illustrated here. So, what are the pathological features of chronically raised PTH level? So, in the first instance, non-autonomous or secondary hyperparathyroidism, which is usually caused by calcitriol deficiency. One area in the world where it's been shown to be due to calcium deficiency would be in West Africa, a place like the Gambia, where there's plenty of sunshine, lots of sunlight exposure, but very borderline dietary calcium intake. But that's a very unusual situation to have secondary hyperparathyroidism with brilliant vitamin D levels. And so the effects of secondary hyperparathyroidism occur on bone mineral metabolism. They cause increased bone turnover with decoupling of osteoclast, this osteoblast activity, causing demineralization of osteoloid and loss of cortical bone in particular, more so than trabecular bone. Chronic hyperparathyroidism predisposes to osteoporosis and fractures predominantly of the appendicular skeleton, things like the wrist, ankle, and also loosening of the teeth. the urine calcium excretion will be low, and there will also be a low normal urine phosphate excretion. Remember, that PTH is desperate to hang on to every bit of calcium, stopping it getting into the urine to try and preserve levels. The serum calcium is usually low normal. Then physical symptoms, which can actually occur independently of either calcium or vitamin D levels. Musculoskeletal aches and pains, fatigue and weakness, sweating and flushing. It's actually one of the causes of non-menopausal flushing and sweating. Hair loss, poorly characterized in textbooks, but actually frequently described in patient websites. And then cardiovascular disease, renin-angiotensin system-driven hypertension, left ventricular hypertrophy, valvular disease, and endothelial dysfunction. So having a high PTH, whatever the cause, seems to drive all these problems. So, what about autonomous or semi-autonomous primary hyperthyroidism? Although in fact, this is also frequently associated with calcitriol vitamin D deficiency. So the effects on bone mineral metabolism are the same as for secondary hyperparathyroidism, but the urine calcium is different. In this case, the urine calcium and phosphate excretion is high, and these patients are at risk of kidney stones. The serum calcium may be high or high normal, and there may be associated symptoms of hypercalcemia. And again, the physical symptoms that can occur independently of calcium vitamin D levels, we've gone through before, similarly cardiovascular disease. So there's a lot of commonality, both in physical symptoms and in biochemistry, between secondary and primary hyperparathyroidism. The two key divergences are serum calcium tends to be low normal in secondary hyperparathyroidism, whereas in primary, it's going to be generally high or high normal. And urine calcium is always going to be low in secondary hyperparathyroidism, but high in primary. So what does the literature tell us about normocalcemic primary hyperparathyroidism? So here we're presuming that there is semi-autonomous or autonomous PTH secretion, but the serum calcium has not gone above range. This hypothesis was first proposed by Rao and colleagues in JCM in 1988, and they hypothesized that primary hyperparathyroidism does not suddenly appear as a fully formed condition. This is the creation of man from Michelangelo in the Sistine Chapel. He is created fully formed rather than as an embryo. Rao proposed that this was unrealistic, that primary hyperparathyroidism had to come from somewhere, and they proposed that there was a biphasic progression of disease. And during the initial phase of autonomous PTH secretion, levels become raised, but not by enough to elevate serum calcium above the reference range. And in fact, there's a model for that in patients with chronic kidney disease, patients with tertiary hyperparathyroidism. So in these patients, you begin with an even earlier phase of non-autonomous secondary hyperparathyroidism before proceeding the development to parathyroid autonomy. So there's another model which would fit with this, how secondary can lead to primary even. Then the idea of normocalcemic primary hyperparathyroidism was picked up again by Belzikian, again in JCEM, and this paper entitled A Form Fruit of an Old Disease. And they, in their center, these were individuals being referred for skeletal evaluation, during all the patients had calciotropic hormones measured, and they identified 22 normocalcemic individuals with high PTH levels, but normal vitamin D and everything else. And amongst these were 20 women, 3 of whom were premenopausal, and 2 men. And that actually just fits with the distribution of primary hyperparathyroidism, the full version with high calcium, so the female predominance and the predominance in postmenopause amongst women. And of these patients, 10 had osteoporosis, 1 had a vertebral compression fracture, 3 had kidney stones, and 8 were kind of like worried well. That was their reason for referral to the clinic. And after up to 12 months of observation, 3 became hypercalcemic, 17 did not, and 1 actually had parathyroidectomy but it's unclear whether that patient was cured or not by the procedure. And so Bilezikian said, well, we hypothesize these patients represent the earliest manifestations of primary parathyroidism. And Bilezikian, being a very influential man, normal calcemic primary parathyroidism was first recognized at the third international workshop on the management of asymptomatic primary parathyroidism in 2008. But I will go back to the data that they presented. So first of all, in that era, they were not measuring intact PTH the way that we do these days. And so not all the patients with a high PTH would necessarily have had a high PTH with our current assays. Second, if you look at the range of serum calcium in these patients, you see some of them had levels that were as low as 2.17, which I would say that's far more consistent with secondary hyperparathyroidism rather than autonomous secretion. And again, the 24-hour urine calcium was not particularly raised. So again, I think that although Bilezikian probably had some gems in there, I think mixed in with his patients was some who just simply had secondary hyperparathyroidism. And we move on to, again, in JCM, played by Liu et al., approach the patient with normal calcemic primary parathyroidism and see what they say. So the diagnosis is challenging and requires that secondary causes be excluded. Absolutely, you know. The natural history remains inconclusive and studies are heterogeneous and follow-up is limited. Spot on. The skeletal and renal complications vary across studies, primarily due to selection bias. So where are these patients coming from? If you're in a kidney stone clinic, compared to are you in an osteoporosis clinic, are you just seeing a well woman clinic? So the kind of patients you'll get in these different clinics are to some extent self-selected. And also in studies to date, really the genetic substrate, particularly calcium sensing receptor, has not really been adequately evaluated. But it's clear that only a minority of cases seem to progress to frank primary parathyroidism, albeit follow-up of longer than 5 years is unusual. It may be that more of them progress given more time. These patients with a normal calcium and high PTH on autonomous, high normal calcium and autonomous PTH, they often present with negative localization, and they might have multiglandular disease, and they're more likely to have recurrent or persistent disease following surgery. So they're not such great surgical candidates on average than the patients with frank hypercalcemia, primary hyperparathyroidism. And even the post-op improvements in bone density or reduction in kidney stones are variable, even when you think you've achieved a cure. And really further studies are needed to provide better evidence-based guidance. So this is a clinical case from my medical malpractice file, and I will walk you through it. So at age 28, this woman presented with left urethric colic, back pain, painful hematuria. I was referred to urology clinic. Adjusted calcium, well within normal limits, 2.47, normal phosphate. Imaging initially showed normal ultrasound and IVU. Again, close to age 29 years, adjusted calcium remained completely normal, 2.49, 2.48, phosphate still normal. But we see that she's markedly hypercalciuric, 11.5 millimole per 24 hours, compared to normal range 2.5 to 7.5. And she passed a stone that she brought to the family doctor. And then finally on imaging, close to age 30, she was found to have 4 tiny left kidney stones. Just after 30th birthday, for the first time, the serum calcium blipped just slightly above normal, 2.61. There was an attempt at extracorporeal shock with lithotripsy, but this failed. She then fell out of follow-up. And this wasn't chased up because that high calcium had actually been measured in by primary care by her GP, not by the urologist, and the level was not communicated to the urologist. And so the urologist was not too disturbed that she failed to attend. So, age 36.1 years, this is 8 years since presentation. She has further symptoms of recurrent left loin pain, hematuria, and passing stones. Imaging shows 3 tiny left kidney stones. Calcium not measured. Age coming up to 40 years, calcium high normal, 2.59, within range. Again, 6 tiny left kidney stones. Age 45.5 years, still with these ongoing symptoms. So we're 18 years since the original presentation. Calcium now becomes unequivocally high and remains high thereafter. And she goes through all kinds of terrible stuff, repeated shock lithotripsy, left ureteroscopy and stenting. One of the ureteric stents really got encrusted with calcium. Attempted removal caused a ureteric tear, requiring nephrostomy. Urine calcium, again high when measured. Just to say, the urologists were not aware of that high serum calcium level. It's measured by the GP, was not communicated to urologists. They did not measure serum calcium themselves. Age 53 years. So, quarter of a century for initial presentation. Finally, someone does all the blood and urine tests. Adjusted calcium 2.73, phosphate normal, PTH high, vitamin D at that point normal range, still hypercalciuric, and the fractionated excretion of calcium well in the range for primary hyperthyroidism at 3.2%. There's further workup done, during which your calcium climbs further, phosphate low for the first time, and she undergoes a curative left inferior parathyroid adenomectomy, following which her serum and urine calcium and PTH levels all normalize. How has she been since? She suffers from the most terrible paresthesia. It seems that having been used to having like a high or high normal serum calcium level for all these years has maybe reset her. And so she experiences terrible hypocalcemic symptoms, paresthesia, even though serum calcium is normal, and she requires cannabinoid painkillers. So I think this case illustrates, normal calcemic primary hyperthyroidism really does exist, and it can be associated with genuine pathology, recurrent kidney stones, and in this case, yes, give it enough time, give it a quarter of a century, it did develop into full-blown frank primary hyperthyroidism with a parathyroidadenoma that was cured by surgery. So, we have a thing called advice and guidance in the UK, whereby primary care will not necessarily do a referral, but they will write an email to you and you respond initially. And one of the really common things was the patient with a high PTH and normal calcium. And the first thing I try and do is I just want to improve the signal-to-noise ratio to get the clearest possible picture, to know where we are. So first of all, is there an obvious cause of secondary hyperparathyroidism to be addressed? Usually, I would aim to correct the vitamin D level to greater than 100 picomole per litre, maybe 40 of your American units, just to remove any possibility of relative D deficiency. I'll want to eliminate any confounding drugs, diuretics, proton pump inhibitors, and of course, rule out patients who've obviously got chronic kidney disease, low EGFR. Second, having done that, what does the serum calcium look like? Is it high normal, in which case this is likely normal calcemic primary hyperthyroidism, but it's semi-autonomous, or is it low normal? If it's low normal, this is likely to be simple secondary hyperparathyroidism. Also, what did the PTH level do? Did it fully normalize with our generous vitamin D replacement? In which case, yeah, this is clearly secondary, or did it fail to normalize? If it failed to normalize and the calcium remains normal, this could either be normocalcemic primary parathyroidism, or it could also be that there's uncorrected dietary calcium deficiency. And you'll see that for what the urine calcium is doing. If the urine calcium is high, that fits with, yeah, this is probably semi-autonomous normocalcemic primary parathyroidism. If the urine calcium is still low, it's, yep, you corrected the D deficiency, but the dietary calcium is also inadequate. And, you know, what's the 24-hour urine calcium doing? Or your morning calcium-creatinine ratio? If it's low, likely secondary. If it's high or high normal, likely there's autonomous PTH secretion. And so this patient, you confirm the diagnosis, and I would see a patient with a confirmed diagnosis not more often than once a year, maybe once every 3 years or so. Most of the rest turn out to have secondary hyperthyroidism. And really, what should we do? Apart from optimize vitamin D and monitor over time. So my aim would be keep the PTH level as low as possible, monitor PTH, bone profile, urine calcium, symptoms, maybe a DEXA scan. Is there a low or declining BMD or rigidity fracture? Because, of course, we know that bisphosphonates don't tend to improve, or they're very good for axial bone density. They don't tend to improve appendicular skeleton bone density or reduce the risk of forearm fractures. At any case, I've discussed the studies before showing that bone-specific drugs, we've no idea whether they reduce the risk of rigidity fractures in primary para and maybe even increase them. Want to know, are there already kidney stones or is there particularly marked hypercalciuria? And at that point you're thinking, kidney stones, is there clear localization on imaging to single parathyroid adenoma? And I think in this case, I would say yes, the younger, fitter and willing patient, refer them for parathyroid surgery. So thanks for listening in. I'm open to questions now, and this is a very nice article here from Stacked Pearls on the condition. Most of the time, it won't be that. Most of the time, the patient's referred, it'll be secondary hyperparathyroidism, but they will come to you sometimes and just carefully consider what you're going to do with them, how you're going to manage them. Thank you.
Thank you so much, Prof. So I invite the speakers and the moderator to the stage, and we'll start the Q&A session. Dr. Hussein.
Thank you very much. Beautiful presentations. Professor Quinton, question regarding the last lecture of normocalcemic hyperpara. Do you challenge these patients with calcium high dose or with hydrochlorothiazide? And a question for Professor Sadat on the animal model with stem cells. Can you tell us a little bit more? Where do you inject the stem cells? In the hip bone, in the vertebrae, or where? Thank you.
So I would first challenge them with vitamin D. If on vitamin D their urine calcium goes high, you have the diagnosis, you don't need to challenge them with calcium supplementation. However, if you've normalized the vitamin D, as I would say in the Malibu Beach range, the PTH remains high, their calcium remains normal, but the urine calcium remains low or low normal, then I would say, okay, let's put in some calcium now, and then see what happens there, see if the condition declares itself. So I would use the urine calcium as a marker of, is it worth challenging the patient with oral calcium? If the urine calcium is already high, I don't think there's any need to do an oral calcium challenge. What about thiazides?
Thiazide challenging test, like do you challenge them with thiazide?
Yeah, you want patients off the thiazides. Yes, absolutely. you want patients of all drugs that could confound things, so thiazides, proton pump inhibitors, anything that messes up the magnesium level. Yeah, just want to improve the signal-to-noise ratio so that you have to minimize the amount of thinking that you need to do. I'm a lazy doctor. I like to make life easy for myself.
The osteoblasts are injected intravenous because there's a tendency of the stem cells, the terminal cells, what we call as the homing of the cells. If you inject neurocytes, they will always go to the neural tissue. Or if you inject osteoblasts, they will go to the bone cells. Or if you inject chondrocytes, they will always incorporate in the cartilage cells.
I have a question here.
Yes, please.
I have one question for Dr. Quinton and one question for Prof. Sadat. I'll start here with Dr. Quinton. Hello. Thank you for the session. It was amazing, both of you guys. And in one of your slides, you mentioned for patients who are on calcitriol, you prefer no oral salt, like calcium salt. And let's say the patient is on 2 mic total. We have 1 alpha in Kuwait. We don't have calcitriol that readily available. Would you increase, assuming that they're on good vitamin D and good oral calcium, from diet, would you increase their 1 alpha further, or would you add oral salt if their calcium is still there symptomatic?
I don't use oral calcium except acutely, so I would just keep on increasing the alpha calcitriol or calcitriol. Obviously, I inherit patients on stacks of calcium, and it can take me up to 2 years to wind the calcium level down. So the only reason that I would give oral calcium salts is if I really think that the patient has dietary calcium deficiency. And again, not more than 500 twice a day. And that's what the ESC guidance would say. If you adjust for all other risk factors, then you should not need to. We don't use oral calcium salts for long-term therapy in Newcastle.
Okay, thank you. And for Prof. Sadat, I wanted to ask, sometimes we get referrals from our neurosurgeon colleagues, spine surgeons, saying that they want to operate on this patient and they want to increase their BMD pre-op. The patient does not have osteoporosis, never had fractures, and they're asking us to use anabolic agents to increase the BMD pre-op, which is not a thing like we do usually for patients who don't have osteoporosis. Have you encountered such referrals, and how would you deal with that if you do? Thank you.
I don't think anybody should do that. Because already if the patient is having a normal BMD, what more BMD will increase?
They want, they have a certain cutoff for their BMD to do fusion surgeries or other spine surgery indications.
You know, I'm a spine surgeon. I operate on scoliosis. Scoliotic children are usually having low vitamin D and low BMD. Still, we don't increase the anabolic agents. No, I don't think so.
So we
it's
just
recommended.
should refuse. Thank you.
No.
Thank you.
Yes.
Ask them to fund a clinical trial.
Thank you very much. Quite elegant presentation, really. Thank you very much. You made difficult issues simple issues. The question I have, if you have someone who's hypopara post-surgery, and they are on calcium supplement, they are on maximum vitamin D supplement, and although there is also issue with compliance here. One, how can you enhance the compliance to take so many? This is one question, and that follows with there. How far could you, if you use teriparatide, when you exhausted all issues, what dose of teriparatide that you would use?
So the way you improve compliance is to get them off the oral calcium because they really hate it. The compliance is much better when they're taking just alpha calcitriol or calcitriol, and the treatment isn't causing them side effects. They're not going through kind of boom and bust. Hypocalcemic, bump up the calcium, dreadful symptoms, stop calcium, go again. So that's one way to improve things. If you are going to use teriparatide, you will need to inject 20 micrograms at least twice daily, if not 3 times daily. I've only been stuck in that situation once, and this was your classic, think about post-thyroidectomy patients, is you'll generally know about them because the thyroid surgeons, you talk to them. The ENT head and neck surgeons, they're not our friends. We don't know about their patients. The first thing we hear about is when they become hypocalcemic. And so this was ENT head and neck patient, cancer in hospital for the summer, post-laryngectomy, had some bowel problems, bacterial overgrowth, and we gave high-dose vitamin D initially. The vitamin D level barely moved. My assumption was the nurses just hadn't given it. So literally, I markedly interrogated them, and I insisted the junior doctor give the same dose over again, visually, and saw it. Again, the vitamin D barely budged. We empirically gave, we didn't have access to a hydrogen breath test for bacterial overgrowth, so we gave empirical rifiximine, and then the vitamin D level went up to normal. We were giving massive doses of alpha-calcidol. We were having to give patients having to receive intravenous calcium gluconate. In this patient, we just needed to get, the patient was going to go home to die, but they were stuck in hospital. And so, yes, finally, teriparatide 3 times daily enabled them to be normal calcemic and to go home to die of their cancer. But that's the only time I've ever needed to use it.
So to allow many to just keep your question short, and please also try to keep the answer short.
May I take this opportunity and ask you, Professor Winken? We sometimes, face patients with clear hyperparathyroidism and hypercalcemia, but the imaging, where the symptom may be or ultrasound fail to show the adenoma. Will you send these patients to surgery or treat medically?
So I will send them to surgery, but advising that they're going to have a bilateral neck expiration rather than, and sometimes what you need is the surgeons mark one eyeball. Sometimes it's the, surgeons, these guys are good with their hands, yeah? And sometimes they will find things intraoperatively that weren't noticed by imaging. So yes, I would, it's nice if you can find a good parathyroid target first. Our preference is to do MIBI-SPECT CT scan. There are also other things, you need PET scans, 4D CT, whatever imaging your surgeon is happier with. But some cases, you have to rely and you have to trust your surgeon to do the bilateral neck expiration and to do as they see fit.
Please, next. No,
yes, please.
Just push up.
So my question to Dr. Sadat, thank you for the elegant lecture, but my question is that, in one of the slides you showed that people in the Middle East, they had much lower risk of fractures compared to European, for example. And if that's the case, why do we have to jump, on giving these women who are above 55 first line treatment and second line and third line? It seems like this is part of their destiny to be on these treatments all their life. I mean, I wanted to hear more about, what risk criteria we will move from first line to second line to third line. In our hospital at Johns Hopkins Aramco, actually, the neurosurgeons and the orthopedic are not privileged to give second line and third line treatment. It's only restricted to endocrine and sometimes rheumatology. And do you have any comments on that?
Yeah, the incidence of fracture which I gave you was the hip fractures, not the other ones. And I'm sure you must have seen your grandmother, and I have seen my grandmother, that as she grew older, the vertebral fracture is the first one which collapses. In front of us, we have seen them bowing down, their height coming down. So to prevent the fragility fracture, particularly the hip fracture, that is the difference of incidence. But vertebral fractures, fracture of the humerus, wrist fractures are very common. They are just the same. And that happens because of a fall. You see, the first line of osteoporosis as per the guidelines by the IOF is anybody who has got a T-score of less than minus 2.5 should have a first-line treatment. That's in addition to that, if they have a high risk of a fracture, like other diseases, then we can go up to an anabolic agent. But usually, the first line is either you give SERMs or you give oral bisphosphonate, or I think they should have estrogen, and I believe that the incidence of breast cancer coming from the West to the Eastern countries are less compared to that. And we did not do any trial. We always follow whatever the West is saying. I was trained in British Midlands. I lived in US. I'm not saying anything against their trials, but the Middle East population is a different population. You can't have the same treatment what we give here to the population in Asian countries. So I did not find a single trial in the Middle Eastern countries where they tried the estrogen levels at all. So unless we do something, we'll be following the guidelines from them. So if a patient has got a high risk of fracture, then anabolic agent is recommended.
Yes, please.
Can I just follow up for that, just to say, one problem in this area is the availability of transdermal estrogens is low. In Qatar, I know they don't have any at all. And we know that the risks of transdermal estrogens in terms of thrombosis, cardiovascular, they're zero. They're just simply not there. But so if you have availability of transdermal estrogens and a modern progestogen, such as natural progesterone, but in my view, for a woman under the age of 60 with osteoporosis, if you're using anything other than HRT, you need your head examined. Honestly, because if they've got osteoporosis at that age, they're going to need sequential treatment. And so go for HRT first, and then you can do other things later.
Short question, yeah. Cool.
Richard, good to have you here in Dubai, all friends. I have a question about if your management strategy on pseudo-hypoparathyroidism, is it following the same steps as hypopara?
Sorry?
Pseudo-hypoparathyroidism.
Pseudo. So it's interesting. Pseudo-hypoparathyroidism, very often, I've inherited patients of the pediatric group, and very often, if you normalize the vitamin D, put it in the Bondi Beach range, they're often okay. They often don't even need activated D. So yes, I broadly use the same line of treatment, except I find them easier to treat. Often these patients who are on lots of calcium and calcitriol and as kids, once the vitamin D level is like above 100 of European units, then it's rare they need much other treatment.
Last question, please.
Prof. Quinn, in secondary hyperpara, so starting these patients on vitamin D and your correct vitamin D, how long you would follow them up before you can see the effect on the PTH levels?
Well, once you start someone on vitamin D, and really it'll take several months for you to then reach peak levels. You need about 3 months to achieve the new steady state, and so at that point there, that's when you would remeasure and see if there's been an effect on a PTH level. Yeah.
Do you come across with patients in spite of doing everything and all the investigations, and still they have persistently raised PTH levels with no more calcium and vitamin D, no more vitamin D, and all the other secondary causes excluded? What do you do in these cases?
I guess you follow them, and usually it'll declare itself one way or the other. You'll see the urine calcium. The urine calcium is the key. Once the urine calcium is above normal, this cannot be secondary hypoparathyroidism. The urine calcium is high in the absence of calcium supplements. This can only mean that there's parathyroid autonomy. And it can take a while for that to declare itself. Time, yeah.
I said last question, but actually I have two burning questions, really. One, if you allow me, one for you, Prof. Sadat. We encounter in a clinical practice lots of patients who are really low risk, I mean by that, no history of secondary causes, no risk factors, no family history, but only a low lumbar T-score. And here some physicians do treat them, others they don't treat them. Do you think that starting HRT versus one dose of IV zoledronic acid, which one of them would be cost effective in such patient in case we don't consider them for osteoporosis treatment, for prevention?
See, estrogen therapy is for prevention. Yes. HRT is for prevention. And I believe that in the first 10 years post-menopause, HRT should be the first in line. The second thing is, for my patient in the university, I love this guy. What we give them, a USB, a flash drive, writing down the details, because if a patient comes to me and I have a plan, if suppose moves from my place to some other place, they should know that the other physician should know what the other physician had given. So at least I give a flash memory to them that this is the treatment which we have initiated, this is our recommendation. If somebody wants to change that, it's up to them. But the first 10 years, I believe that HRT is an answer, which we have been, and I still believe, I told you that the WHI study is misinterpreted. And that is the reason why nobody uses HRT anymore in the Middle East. And I am sure now the UK and EU is coming back to HRT.
The European Society of Endocrinology menopause guidance has just been published. And what they say is that even in a woman without menopausal symptoms, you should consider HRT for primary treatment of low bone density. Whereas previously the British Menopause Society said, oh, well, no, you had to have menopause symptoms. And so I think that's what the ESC is saying. Again, I think it should be stronger rather than consider. I think it should be absolutely first line. But, sometimes revolutions come slowly. It's best not to push things too hard, but just to move things slowly.
Thank you.
The oral bisphosphonate was particularly, I have seen 60% of my patients, they stop taking it. And we think that they are taking it, and then they will sustain a fracture. So this is much safer, and the studies have shown that the transdermal combination is much better, estrogen. And plus nowadays they have what we call as progesterone intrauterine device, which works for 5 years. You inject once, and then 5 years you forget about it. They take oral transdermal every month. That's fine.
And you can assess it. You could measure an estrogen level. You know whether they're taking it.
Actually, just a comment. Here I would speak just about our practice in UAE. The women at the transition period or menopause now are educated. And we are getting now, and we are seeing more women asking for HRT. So the practice is changing.
That's good for you.
Definitely.
Yeah. And you'll also reduce risks of hospital admissions with urinary tract infections later in life as well. Our A&Es in Britain are full of elderly ladies with either with urinary tract infections, dementia, delirium or something. And that's all caused by chronic urogenital atrophy.
Now we reach the end. Thank you so much, Prof. Sadat. Thank you so much, Prof. Richard. Thank you, Dr. Abdul Razak and Dr. Salwa. Thank you for all the audience for your interaction and for staying to the end.